Welcome back. We are starting to. Welcome back, everyone. We are moving on to our next session, which is pertaining to cancer. I would like to invite our chairperson on the stage, Dr. Harit Chaturvedi, sir, Chairman, Max Institute of the Cancer Care, Max Healthcare, New Delhi. Dr. Ravin Kumar Diwan, Director, National Institute of Tuberculosis and Respiratory Diseases. And Dr. J.K. Saini, sir, chest specialist and head of the Department of Pulmonary Oncology, NITRD, New Delhi. Welcome, sir. So we are starting with our first speaker, Dr. Pooja Khaitan. She is Associate Professor in Thoracic Surgery, Georgetown University Medical Center.
How many people have joined online?
Online, sir.
Online, how many people have joined us?
Online.
13 people have joined online. We are likely to be joined by more people. And this program will also be available on YouTube later on. It's being live streamed through the Eco platform. Okay. Yeah, we can start, because if we lose time, then we will be losing.
Absolutely.
Yeah. Dr. Pooja, please. Thank you.
Please.
Good morning, everyone. Thanks for the invitation. Thanks to the program committee for organizing this very nice day today. So yes, understanding my audience, I'm going to be pretty much discussing the basics of esophageal cancer. How do you work up patients with esophageal cancer, and what's the current line of treatment? So in the next few minutes, I'll talk about definition of early stage esophageal cancer, and discuss some endoscopic resection and then standard of care for regionally advanced esophageal cancer and other role of our surgeries. So starting with Barrett's, which is the prelim diagnosis of esophageal cancer and the progressive disease, you can clearly see that there are salmon-colored mucosa that's coming up into the esophagus, into the across the GE junction, thus predisposing a patient to develop esophageal cancer if left untreated. This is a specimen sample of what a normal esophagus looks on an endoscopic view on the right. With a pathologic specimen, you can clearly see the Z line where the esophageal white mucosa turns into this gastric rugal folds. This is a normal view of the esophagus under NBI mode, narrowband imaging mode, which uses two different filters of wavelength of light in order to visualize the esophagus. You can see a nice mucosal plexus there. There's no evidence of Barrett's here. But if you actually see on NBI mode these white-colored plaques, these essentially are diagnostic of Barrett's esophagus. And this is a patient who's got different nodules, very suspicious for esophageal cancer. On an NBI mode, you can clearly see that these don't take up the normal mucosal plexus of what it should be as of a normal esophagus. So as we all know, TNM staging is the way you classify esophageal cancer. Once you diagnose esophageal cancer with a biopsy, you have to do an ultrasound and stage the patient. So the T1, T2, T3, T4 are essentially based on the depth of the tumor into the esophageal wall. The in situ tumor is basically involving the muscularis lining, and as you go in T1 and T2 across the muscularis propria, you end up entering the T3 into the adventitia and T4 into the beyond the adventitia into adjacent organs. Obviously, the deeper the tumor, the higher the chance of having lymphatic invasion, because the lymph nodes and the lymphatic channels travel beyond muscularis propria. Hence, T2 is the cutoff. That is one of the more important points to remember. Just like colorectal cancer, this is very important for examinations and remembering your management of patients. So the way once you've diagnosed, the next step, as I alluded to before, was endoscopic ultrasound, EUS, where you stage the tumor and the depth of the tumor and also look for regional lymph nodes. So on the top, the images reflect an EGD scope, a side scope of the ultrasound, and a radial scope. The one that we tend to use is the radial scope, which is on the bottom image as well, with a balloon that's already uploaded onto it. And you can inflate the balloon with water so that you get good apposition with the esophageal wall and be able to understand exactly how deep is the tumor. So when you're looking at the EUS, the things that you look for, is it T1A or T1B, because that makes it an early stage esophageal cancer, and they can be treated differently, which I'll get to in a few minutes. Is it in a T2 tumor, and do you need to talk about regional invasion? If it's T4 and it's invading the aorta, the pleura, that also changes your management, and then you look for nodal status and nodal staging with an FNA needle. So the layers of the esophagus, when you're looking at the EUS, this is a nice endoscopic view of the EUS scope, where you can see a tumor would invade into the muscularis, mucosa, propria, beyond into the adventitia, and then beyond the adventitia into the adjacent organs in the aorta at like 1 o'clock position on this image. So the treatment algorithm for esophageal cancer is different. Once you've made the diagnosis of esophageal cancer, you would then undergo staging process, which includes the EUS as well as the PET scan to look for any metastatic pathology. And then you decide what stage of the tumor is it, early stage, localized, or advanced stage. If it's early stage esophageal cancer, which is T1A and T1B, you could consider this patient to undergo an endoscopic resection or an esophagectomy. However, for the most part, if you have endoscopic modality available in your city or in your neighboring institutions, you should refer the patient outside if you're not, instead of committing the patient to esophagectomy at your own institution. So EMR was, or ESD, which is endoscopic submucosal dissection, was mastered and pioneered by Dr. Inoue from Japan. And essentially what this is shaving off the tumor in the esophagus. When you're doing EMRs, it's extremely important to define the lateral extent of the lesion and the depth of the lesion so that you make sure that you understand how deep is this tumor and can it undergo EMR. There are multiple different techniques for EMR described in the literature. You don't have to know all of them, but the important points I'll go into in a few minutes. But there's a lift, suck, and then cut the tumor. There's a ligate and cut the tumor. You can cap and snare method, which is one of my favorite ones, and as well as the multi-band mucosectomy, which is also a very nice, simpler way of doing EMR. So basically, when you find the tumor, you first do a submucosal injection or subcutaneous injection to lift the tumor. When you're injecting, you're basically injecting fluid in the space in the submucosa. And in the past, we all used to do methylene blue, but the problem with methylene blue was that you have a little spill and everything becomes blue. So now we've just started doing saline injections. And if the tumor lifts, this is the key, if the tumor lifts away from the ball, you can tell that this is not a deep tumor, and you can pretty much do this endoscopic resection without having any positive margins left behind. Then what you do is this device, the special endoscope, you have the ability to suck the nodule inside it, and then you have these multiple bands that are loaded up on the device itself, and one by one you can deploy them, and then you can use a snare. Either it's a hot snare that comes to the same endoscopic device, either above or below. I prefer the below technique because you actually got the negative margin below the rubber band. The multi-band mucosectomy also looks a lot like the same. It just has a different type of a capping system and a wheel that allows you to do a mucosectomy. And this is what it looks like. So after you've done the resection, this is the multi-band mucosectomy. You can see that the little lesion is there, and you're able to pluck it. And when you come back behind, you can see how nice in the C panel, the little shaved off bed is left behind. And here's a specimen. You can take the specimen on your back table. The hard part with these Mucosectomies or endoscopic resection is you don't know what's positive in the end, in the sense that you know if the deep margin is positive, okay, fine, then you either need to go back and get more tumor or you need to commit this patient to an esophagectomy. But if the lateral margin is positive, it's really hard to tell which lateral margin was positive after you've removed it because you lose the orientation. So unless you know that there was more tumor left behind on, say, 5 o'clock or 3 o'clock, you can go back and get it. But otherwise it's a little bit more difficult. So that's the advantage of endoscopic submucosal dissection. So EMR and ESD, the indications are typically TI in situ tumors, T1A, or superficial T1B lesions. You should not have any lymphovascular invasion. According to the NCCN guidelines, if a patient has any of these poor features of LVI, poor differentiation, or greater than 2 centimeter lesion, you would be doing a patient a disfavor by endoscopically resecting the tumor. Some of the caveats of EMR, like I said, there's a higher chance of recurrence after a piecemeal resection, especially if the margins are left behind that are positive. Sometimes it's difficult to evaluate the margins, especially the lateral ones, and difficult to determine risk of lymph node metastases, right? I mean, you could have seen that on an EUS, but if the lymph nodes were small and pathologically did not appear abnormal, you may not have done a biopsy on them, so you may be missing them. And as we all know, about 10% of patients can have lymph node metastases, even with T1A lesions. So one of the important points that we discuss in doing EMRs is the depth of submucosal invasion. It's a no-brainer to have M1, M2, or M3, which is the muscularis mucosa invasion. But when you have submucosal invasion, you can divide that into 3 groups, SM1, SM2, SM3, standing for submucosal 1, 2, and 3. And depending on how deep the tumor is on your endoscopic ultrasound, you can decide whether or not this patient would be amenable for an endoscopic resection. Anything at SM1 is reasonable to do. SM2 and SM3 are higher risk for lymph node metastatic disease. So sometimes with SM3 invasion, where the tumor is going all the way up to muscularis propria, you should not consider an EMR. So the outcomes are excellent. I won't go through all this, but the important points that I will highlight is that with EMR and good EMR surgeons who've done many, many procedures, this is a paper of 1,000 patients. Complete resection is possible with 96% success, and long-term remission rate has been reported as high as 94-95%. ESD is for tumors that are greater than 2 centimeters. It's endoscopic submucosal dissection. I have to admit, I have not done endoscopic submucosal dissection. I've only seen them performed. But essentially what it takes is you have to do the same sort of an injection endoscopically. You make sure the tumor lifts off, and then you do a submucosal shaving of the tumor with a special blade to do the complete resection, ensuring that you have good negative margins. Obviously, higher chance of perforation, higher chance of bleeding compared to EMR. And this is what it looks like on a specimen. You've done you've got a patient with Barrett's, and this was with high-grade dysplasia features, and so then they were able to lift this nodule up. In fact, hard to tell which nodule they're looking at, but on B figure you can see how the submucosal dissection has started, and it's proceeded further down, and then the whole specimen is removed. Also, with good outcomes, obviously you have to have good patient selection. R0 resection was possible in 77%, and a 5-year overall survival and disease-specific survival up to 90 and 100% respectively. Moving on to localized esophageal cancer or regional esophageal cancer. So patients with T2, T3, node positive, as long as they don't have any metastatic disease on a PET scan, could be considered for resection. According to the CROSS trial, they should all undergo neoadjuvant chemoradiation. That's not standard of care across the globe. Some people will just put them through neoadjuvant chemotherapy, followed by surgical resection. This is not what we advise anymore, so you should not be doing this. Just a joke. The types of esophagectomies that is important for the audience to know are 3, basically Ivor-Lewis, 3-hole or McEwen esophagectomy, or transhiatal. If the stomach is not available and you are not able to use the stomach as a conduit, the other options that I will not go into are colon interposition and jejunal interposition in order to reconstruct the esophagus and have GI continuity. So this is what an Ivor-Lewis esophagectomy looks like. It's typically started in the abdomen, where you first mobilize the stomach and make a conduit and then go into the chest and make your anastomosis. This is basically in the chest where the anastomosis is made, and this is what it looks like. So the stomach gets pulled up, you have the anastomosis above or below the azygos vein. A 3-field or a McEwen esophagectomy, you start in the chest, mobilize the esophagus, go in the abdomen, make the conduit, and then pull it up in the neck and make the anastomosis. Basically, this is what that is. And then transhiatal is you have no incisions in the chest itself. You do the neck and the abdominal dissection at the same time, and you advance, do the whole dissection manually, make the conduit, and then pull it up into the neck. Sure thing.
I think that will give us some time for question or two.
Couple of questions.
Yes, sure. So EMR ESD is successful with complete remission up to 96% for early stage esophageal cancer, and patients who have T2 and node positive disease should be considered for cross trial prior to undergoing resection. And then surveillance and complementary endoscopic eradication therapy is critical to achieve optimal patient survival. Thanks.
Thank you. Thank you. We'll take a couple of questions from the audience. Meanwhile, I'll ask a question to you, Dr. Pooja. How do you tackle thoracic duct? Do you look for it, or you just wait for anything for thoracic duct?
Thoracic duct, no. So I look for it only if I'm in the general vicinity and I have concerns that I may have nicked it. But we don't typically look for it just to look for it, because as you all know, the more you look for it, the more higher the chance that you'll injure it. And of course, sometimes you're wrong and you did nick it and didn't realize it, and then you deal with the chylothorax.
Because we look for it and clip it as a routine, so
I
it's
see.
usual practice, yeah. Any questions from the audience?
Any questions in the chat box? Somebody is looking at the chat box also?
How do you select your patients for NACTRT or NACT? Or there's any criteria you're practicing? Or?
If they've had radiation in the past, then you may not be able to give
Histology
them additional
or
radiation.
location?
No, in fact, we would, at least in the US, we give chemoradiation to almost every patient if they qualify.
Okay. Thank you. Thank you.
Okay then, thank you.
Thank you.
Yeah. It's my pleasure to invite Dr. Devyani. She's here.
Okay.
Yeah, Dr. Devyani is here. Yeah.
Yeah.
So it's my pleasure to invite Dr. Devyani Nyogi. She is the Associate Professor at Tata Memorial Hospital in Thoracic Surgery Unit, and she's doing work in all spaces, lung, mediastinum, esophagus, everything. Dr. Devyani. Her topic is SPN.
Good morning, everyone, and thank you very much for having me here on this beautiful morning. The topic we're going to cover in the talk today is an approach to a solitary pulmonary nodule. The first thing we need to do is understand what this entity involves. Solitary is self-explanatory. It's a nodule which is typically less than 30 millimeters in size, within the normal aerated lung parenchyma, with no other coexisting pathology within the chest, no collapsed lung, no mediastinal nodes, no pleural pathology. That is when it is called a solitary pulmonary nodule. The minute the size goes above 30 millimeters, it is known as a lung mass. And the minute this magic number of 30 is breached, the chances of that lesion being malignant goes as high as 90%. These nodules are almost always asymptomatic. So you can either detect them during lung cancer screening, where the pickup rates are pretty much higher, or it can be an incidental finding when there is a CT chest done for any other reason. The most popular recent reason being COVID-19, people came with a slew of CT scans with a lot of nodules detected, which further needed follow-up. They can be benign, pre-malignant, or malignant. The pre-malignant malignant spectrum has in situ cancers, non-small cell lung cancer, carcinoids, or even metastasis from other tumors. And various series have reported the malignancy rates from 10% to as high as 70%. When we see a solitary pulmonary nodule, we have to keep a very clear goal in mind as to what we want to achieve while managing this. The most important thing is to identify an early malignancy. And this, I would say, is extremely important because if we pick up stage 1 lung cancer early enough and treat it within good time, they can have a 10-year survival of as high as 90%. So this is too good a chance to miss by. But at the same time, what is important is we need to reduce the chance of over-investigation, and the potential for that in this kind of scenario is extreme. So the trick is to find the right balance. How do you identify an SPN? X-rays are really not reliable. As you can see in the X-ray put up here, it's almost a normal looking X-ray on the top, but the patient actually has a pretty large lesion in the anterior segment of the upper lobe, which is masked because of the hilum and the post-hilar shadow. Lateral projections are slightly better, but still X-ray is not what you'd rely on for a solitary pulmonary nodule. What is recommended is a low-dose CT thorax. A low dose is 1.5 millisievert, and that is keeping in mind the possibility that repeated CT exams might be needed for this patient during follow-up. The sensitivity for this modality is pretty high, and the section thickness recommended is somewhere between 1 to 1.5 millimeter. The BTS guidelines say 1.25 mm sections. This also has its pitfalls because lesions which are purely endobronchial or near end-on vessels may not be appreciated, and sometimes the respiratory motion itself may cause missing out on smaller nodules, for which a breath hold CT is what is now recommended. Who are the stakeholders who decide what to do with a nodule once it is seen? There is a radiologist who picks the nodule or does a biopsy, a pulmonologist who deals with it or probably the patient goes to for the first time, surgeon when the nodule needs to be excised, the pathologist who will try to see what this nodule was, but most importantly the patient. So whenever dealing with this, we need to see what the risk appetite of the patient is, how reliable she or he is for follow-up while we make our plan. The management depends on the risk factors of the patient, like smoking or diabetes or pre-existing lung conditions, the current imaging that they have come with. If they have a previous imaging, it's always helpful because it helps you compare the nodule and see how it's progressed. And finally, based on the guidelines that we'll now discuss, we decide whether or not to go ahead with a tissue diagnosis. Nodules can be solid, part solid, or pure ground glass. The first thing that we need to look at while looking at a nodule on a scan is the size of the nodule, which is generally measured on the lung window, but it is recommended to shift windows to assess the solid component appropriately. The axial plane is most commonly used because it is one that is most reproducible, especially when serial scans are done. Increasing size is associated with an increased risk of malignancy. Less than 6 millimeter, the risk is less than 1%. But the minute it goes above 20 millimeter, the risk is as high as 60 to 80%. Upper lobe lesions have a higher chance of being malignant. Periphyseal or pleural-based lesions, like seen in this scan, are less likely to be malignant. Spiculated margins is classical for lung cancer, but not always, because metastatic lesions may not have spiculated margins. Fat density or popcorn calcifications within a nodule indicate a benign pathology, but again, with the caveat that this may not always be true. For example, if you look at the scan of the OGS lung met, these mets are ossified and can very well look like a calcified lung nodule. So the history and looking at the patient as a whole is very important while evaluating these nodules. Contrast enhancement and displacement of vessels and bronchioles is classical of a malignancy, as against a consolidation patch as seen in the scan, where the general parenchymal architecture is maintained. Next comes the volume doubling time, which is a new kid on the block and the most sensitive method to look at a nodule, which looks at how quickly the nodule doubles its volume. So if it is less than 400 days, that means it's a relatively fast-growing nodule and it has a high risk of malignancy. More than 600 days, most likely benign. Again, if it's extremely fast-growing, a volume doubling time of less than 20 days, it is surely, it means it's an infective process going on. There are a number of guidelines that help us put all this into one place and go through a systematic method of identifying a nodule and dealing with it. The most commonly used guidelines are the BTS, which was updated in 2017. Without going through the details of the guidelines, we'll just see the important part. Any nodule less than 5 mm or a patient who's unfit for further therapy need not be investigated further. 5 to 8 mm is what needs further follow-up scans to see how the nodule is behaving. The minute it goes above 8 millimeter, you need to start assessing the risk and then deciding how to deal with this particular nodule. There are various models available for this which take into account risk factors, nodule characteristics, and patient characteristics. Anything which has less than 10% risk of malignancy, follow-up. Anything more than 10% needs a biopsy, surgery, or some further plan. The guidelines are slightly different for subsolid nodules. The most important difference being repeating a scan at 3 months. Because in subsolid nodules, if the nodules have to regress, it will regress by 3 months. At 3 months, if they remain stable or if they progress, you have to go through the entire guideline again, like for the solid nodules. When do you use a PET CT within this context? First of all, it has to be a fit patient who's amenable for any further treatment. Only then will you invest in something as expensive as a PET CT. The risk of malignancy should be put as higher than 10% according to the guidelines. The size of the lesion should be more than your local PET CT threshold, which for most institutions is about 8 millimeter to 1 centimeter. Nodules smaller than that won't be picked up on PET anyway. And sometimes PET can be used for guiding biopsies in heterogeneous lesions where getting a positive diagnosis is proving to be difficult. A biopsy is preferred over an FNAC because it gives you more tissue to analyze. For most lesions, we use percutaneous CT-guided biopsies using a coaxial system. But the risk of hemothorax, pneumothorax is not insignificant while doing a percutaneous biopsy. Lesions that are purely endobronchial need a bronchoscopic biopsy. And now to even further mitigate the risks of pneumothorax, we have newer techniques like the radial EBUS or navigation bronchoscopy. Finally, if it has to come out via a VATS wedge, which can then be sent for a frozen section analysis and further plan made. This is a video, I hope it plays, which shows a navigation bronchoscopy where you navigate through absolutely peripheral bronchioles using either electromagnetic navigation or percutaneous fiducials. You pass an extremely slim scope through the distal most of bronchioles and take a biopsy through the lesion. If the patient comes to you as a surgeon and you need to take the nodule out, the first thing we need to think of is how to localize this nodule because most of these are extremely small and usually impalpable. We commonly use the hook wire localization with our IR colleagues. You can also use microcoils or fiducials, but then you need fluoroscopic guidance within your OR to be able to wedge the nodule out. You can also inject lipidol and again use fluoroscopic guidance. Or the most state-of-the-art technique nowadays are the hybrid operating rooms, which have CT scanning machines inbuilt into the OR so that you can make sure that you're removing the nodule in question. COVID changed a lot of things as far as SPNs were concerned. A lot of scans were done, more nodules were picked up, a lot of patients became very anxious about the nodules. It also led to interruption in follow-up protocols and lung screening, more relevant abroad than in our country. And what we also saw in our institution was a surge in early lung cancers, people coming up with T1 lesions, which till then we could barely ever see. AI is coming in a big way as far as SPNs go. Through deep learning methods, we hope that they can automatically detect, characterize nodules, and also assess the risk of malignancy over time. But the current limitation it faces is the high number of false positives seen with AI. So as of now, the role is limiting to augment a radiologist's reading of a scan and not use AI by itself. In conclusion, solitary pulmonary nodules are more common than we think. We have to find the balance between detecting early malignancy but avoiding over-investigation. Each patient, each nodule is different. There are guidelines in place, but we have to tailor our approach according to each patient. Thank you very much for your time.
Thank you, Dr. We'll take a couple of questions. So according to the algorithm, we have to investigate everything beyond 8 millimeters.
Yes, sir.
Is that what comes out? So what will be the first thing as an invasive procedure? Because bronchoscopy, and we don't have access to thin bronchoscopes. So
more than 8 millimeter, I think the first go-to would be to check with our interventional radiologists whether they can get an FNA or preferably a biopsy. If they can, that would be the procedure of choice. But if they can't, then it would be a nodule localization and a wedge resection.
So localization, you mentioned about the JWire. So JWire is definitely available, doable, but my worry is that even then you need a C-arm.
Yes.
Without a C-arm, even a JWire doesn't work so
Absolutely.
well. So even a fiducial will do as well as a JWire for that.
So, yeah, and the risk of dislodgement for a fiducial is much less because there's no
Yes,
overhanging component
yes.
of the
So
wire.
that's what I also feel, that fiducial is more
Yes.
useful than a JWire. Yeah.
Dr. Ashish, you would ask me.
So, thank you. It was a nice presentation.
Thank you very much.
So, I want to know about the screening part of thing. So, is there any guideline in India to guide physicians to whom we screen? We see COPD patients in our OPD, 30-pack years, they are taking the smoking. So, is there any guidelines so that we can be guided by that, to whom we screen?
So currently, the recommendation for screening is for high-risk population. So like you said, the population that you're seeing, more than 30 pack years of smoking, who haven't quit in the recent past, they are people that you want to screen. There is no national guideline in place as yet in India, but what we follow is opportunistic screening. So if you get a patient who fits the bill in terms of risk, and if the patient says that they are anxious about this, is screening a good option for them? Then yes, screening is a good option, but it comes with the caveat that if you do detect a nodule on screening, you need to have the resources to follow it through. So there is no point in screening if we don't have the resources to follow up the nodule. So, but it needs to be a conversation, and it can only be opportunistic as well.
Ma'am, my second question is, if you find PET test scan negative, then you will go for biopsy of SPN or will not go?
So, like I said, the PET scan is slightly limited in its capacity to evaluate smaller nodules. So, if it's a very small nodule, it may not pick up on PET. But if the risk factor and the radiological characteristics are suspicious enough, you would be safer erring on the side of a biopsy than leaving it alone.
Thank you, sir.
Dr. Devyani, one question, because we in India see a lot of X-rays which have some nodules because of previous tuberculosis lesions. Now, such a patient can also develop a malignancy.
Absolutely.
So, where will you think that we should be watchful? Just because a patient is follow-up, he is known case of TB, and we may miss the opportunity to develop malignancy.
So actually, sir, the series from our hospital itself, which looked at solitary pulmonary nodules, showed that it was related to infectious processes in as high as 20%. So that's quite a high number. Hopefully, a patient with a past history of tuberculosis will have previous imaging. So if you see something new, then it would be prudent to have a follow-up surveillance protocol and look for any changes. But if it stays stable over a decent amount enough of time, then probably we can stop surveillance, saying that it's not important enough.
Sir, maybe request the chairpersons to kindly go to the next talk, sir. We want to respect the other speakers.
It's okay, please. Thank you.
Just one
Thank
small
you.
comment. Devjani,
Dr.
it was clear articulation. I am very happy. Just tell me, the COVID has made us ambitious. Surge of detecting solitary pulmonary. What is your suggestion to modify screening modules so that this ambitiously getting chance of identifying solitary nodule is maintained? Modification of screening methodology, if any idea?
Unfortunately, in India, I think we are grappling with so many issues right now that lung cancer has still not reached a place where it's become something of national importance. I hope we don't see that day, but if we do, then screening should come into the guidelines. As of now, I think we are duty bound to, at least in the centers that we work in, offer screening to patients that we feel will benefit from it. And I think it should start there.
Thank you.
Thank you so much.
Thank you.
Very interesting talk. Actually, we had a talk on screening also by Dr. Priya, but is it there? It's not.
No,
there.
sir.
Okay. Yeah.
So it's my pleasure to invite Dr. Bhushan Tambre. He will be talking about diagnosis, staging, fitness evaluation for patients of CL lung. He is a fantastic thoracic surgeon doing uniportal VATS and robotic, and he's the right person for this.
Good morning, chairpersons. So I will be restricting myself to specific things like diagnostic, staging and fitness. So no disclosures, no funding. So Globocan data shows that lung cancer incidences is increasing, and it is one of the, I say it is a king of cancers, and with a high mortality rate, leaving behind all the other cancers. You can see from this data that 15,87,000 incidence is there, and mortality, the higher mortality is there compared to the other cancers you can see. So what are the types of lung cancer? Small cell carcinoma, and non-small cell carcinoma. Non-small cell carcinoma, three main types: adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. So, how do you diagnose a lung cancer? So, what are the common clinical features? So, cough, breathlessness, hemoptysis, anorexia, weight loss. These can occur in any infectious diseases also. These can occur in tuberculosis, aspergilloma, lung abscess, non-infectious autoimmune diseases, vaginous granulomatous. Then how you diagnose it? So sometimes patient may present as symptoms due to its metastasis, a liver lesion detected incidentally, or due to bone pain, fracture, or any seizure episodes, or subcutaneous nodules. So from where do we take this specimen, or how do we confirm a diagnosis? So there are two modalities. One is imaging, and then is the tissue diagnosis. I will come to the imaging part later. First, we will discuss with the tissue diagnosis, from where exactly we will take this specimen, from the lung or a mediastinal mass, or a patient sometimes may present with pleural effusion, a cervical lymph node palpable, or a axillary lymph node, or he might be having liver or adrenal SOL, or a visible swelling in skin, soft tissue, bone. These are the methods for tissue diagnosis of lung cancer. So FNAC, or a true-cut biopsy from a large palpable lymph node. Conventional bronchoscopy, brushings or washings can be taken if it is a centrally located lesion and within the reach of a bronchoscope. Computed tomography, directed transthoracic needle aspiration, or a true-cut biopsy can be taken. Transbronchial needle aspiration for centrally located lesions. Nowadays, electromagnetic navigation bronchoscopy is coming up, as demonstrated by Dr. Devyani. And sometimes pleural biopsy, ultrasound guided biopsies, Putum's cytology also can give a clue to the diagnosis when the tumor is inside the air spaces. Thoracocentesis, and now once you have taken the sample, there is a big role of a pathologist. No talk will be complete without mentioning the role of a pathologist. So there has to be histological subtype: NSCLC, adenocarcinoma, or a squamous cell carcinoma. And if NSCLC lack a definite morphology, then immunohistochemistry comes, and definitely in today's era, immunohistochemistry plays a major role in diagnosis of and differentiating different cancers. So, for example, adenocarcinoma, TTF1 and napsin A should be positive. Squamous cell carcinoma, P40 and P63 should be there. There is a group called NSCLC, not otherwise specified. When specific diagnosis is not possible by both and IHC, then only this has to be mentioned in the report. Molecular testing, nowadays we are doing more and more of molecular testing as the immunotherapy is becoming more and more advancing. So we will need more and more these even in the operable lung cancers. These are EGFR ALK rearrangements. These has to be done in all NSCLC, and optional markers are PDL1, ROS1, BRAF. So what are the commonly used antibodies in lung cancer? So markers for differential diagnosis of carcinoma from likely lung origin. So TTF1, P40. Other markers are CD56, cyanectophycine, chromogranin A, where the morphology is identified. The markers in differential diagnosis of adenocarcinoma, where TTF1 is negative or an unknown primary is there. Still we will do TTF1, PAX8, GATA3, CDX2, CK7, CD20, or PSMA or NKX 3.1 for men, to distinguish from prostate and other cancers. The markers for epithelioid undifferentiated neoplasms, where there are secondary tumors, already patient is having head neck cancers and having a lung nodule. Then pancytokeratin, AE1 by AE3, CAM 5.2, S100, desmin, SMA, CD34, CD31, CD45, calretinine, OCT4. So what are the molecular markers in lung cancer? So these are the most common are the EGFR mutations. Most commonly used, and day-to-day practice you see a lot of samples with EGFR reports. ALK rearrangements, ROS rearrangements, BRAF, MET alterations, RET arrangements, ERBB2 or HER2 mutations or KRAS mutations. So now we will come to staging in lung cancer. So why staging is necessary? As we see ISLC data, so you can see from the graphs, as we stage the disease and we categorize the patients according to the stage, the survival is different for each stage. So this is very important, and you can see the difference between the clinical staging and the pathological staging. So as pathological staging, especially after you resect the specimen and hand it toward the pathologist and he stages all the lymph nodes and the specimen, then you can see the survival. So what is staging in lung cancer? So now latest going on is AJCC 8th edition. So we have preoperative imaging or the clinical classification, ITNM or CTNM. Definitive pathological staging, PTNM, there is definitely restaging after initial adjuvant therapy or chemotherapy, YTNM, and staging of recurrence is RTNM. So now we will come to the definite components involved in the staging. So T0 is there is no primary tumor on imaging. T is carcinoma in situ irrespective of the size. This can only be diagnosed after resection of a specimen or a wedge of the lung or whatever. T1 is, you can see a small tumor less than 3 centimeter in size. Now it has divided into T1, T1A, T1B and T1C. T1A is less than 1 centimeter, T1B is 1 to 2 centimeter and T1C is 2 to 3 centimeter. This is the size criteria. There is something T1A MI, when the pathology is proven, it is called minimal invasive irrespective of the size. T1A superficial spreading tumor in the central airways irrespective of the location. This might be lipidic pattern type of growth. The T2, now the size criteria for T2 growth is at 3 to 5 centimeters. The tumor and the tissue criteria is tumor of any size that invades the visceral pleura, involves main bronchus but not the carina. Shows an atelectasis or obstructive pneumonitis that extends to the hilum. T2 has been categorized into T2A and T2B. So T2A is 3 centimeter to 4 centimeter, T2B is 4 centimeter to 5 centimeter. So now coming to T3 centimeters. So T3 centimeter, the size criteria is 5 centimeter to 7 centimeter, except the Pankos tumors which involves the nerve roots are also included in this, and tumors of any size that invades the chest wall, pericardium, phrenic nerve, shows one or more satellite nodules in the same lung, same lobe. T4 tumor size greater than 7 centimeter, Pankos tumor that involves C8 or higher nerve roots, brachial plexus, subclavian vessels or spine. Tumor of any size that invades the mediastinal fat, mediastinal structures, invades the diaphragm, involves the carina, or one or more satellite nodules in another lobe on the ipsilateral side. Okay, this is a simple chart which you can put in your OPD where you deal with regularly lung cancer patients. So now coming to the nodal status. So nodes are categorized in N1, N2, N3. If the nodes are on the same side of the left border of the trachea, N1 nodes are ipsilateral nodes up to the hilar nodes, level 10 nodes. N2 nodes are the nodes present on the ipsilateral mediastinal or subcarinal level. These N2 nodes are defined by the left lateral border of the trachea. N3 nodes represent contralateral mediastinal or the contralateral hilar or or scalene or supraclavicular nodes. This is the nodal classification or regional classification of the lymph nodes. You can get it anywhere. So for a right lung tumor, N1 is ipsilateral peribronchial hilar lymph nodes. N2 is 2R, 3R, 3P, 4R, 7, 8 and 9. N3 contralateral, any nodes in the opposite side are N3 nodes. So you can see from the diagram, these are the right side, the green ones are the N1 nodes and the orange ones are the N2 nodes. Now same for the left side, you can see the 2, 4, 5, 6 are N2 nodes and the hilar nodes are the level 10 nodes. So N can be subclassified as N1, N1A single station N1 involvement, N1B multiple station N1 involvement, N2A single station N2 involvement without N1 involvement, N2 single station N2 with N1 involvement, N2B multiple station N2 involvement, and N3 lymph node involvement. So M staging, no distant metastasis. M1 has been categorized into M1A, M1B, and M1C. A is regional metastatic, defined as malignant pleural or pericardial effusion, as well as contralateral or bilateral pulmonary nodules. M1B is solitary extrathoracic metastasis or any oligometastasis. M1C is multiple extrathoracic metastasis, either in a single organ or multiple organ. This is a simple chart you can keep in your OPD to stage the disease. So stage 1 and 2 are early lung cancers, stage 3 are locally advanced cancers. What are the tests to be done for the staging? Essential for all cases are contrast enhanced CT scan of thorax, which should include upper abdomen, liver and adrenals. Essential and preferable is bronchoscopy or upper GI endoscopy, from where procedures that includes a bronchoscopic biopsy and includes EBUS or EUS to get the tissue sample. Thoracoscopy, medical or VATS in case of pleural effusions depending on the situation. Mediastinoscopy for staging, CECT scan or MRI brain for doing the metastatic workup, and a whole body PET scan. So when to stage? As soon as the diagnosis of lung cancer is confirmed, preferable after neoadjuvant therapy for potential resectable NSCLC or persistent multi-station non-bulky N2 disease, where surgery versus CTRT is the question, and can be done for relapse cases after initial curative intent, and some have progressed after initial treatment for metastatic disease. So what is the fitness evaluation for lung cancer surgery? So evaluation of respiratory system, evaluation cardiovascular system and other systems. So apart from the nutritional status and his blood reports, his serum protein levels and his ECOG status, these are the specific tests for looking for the patient for a lungs resection surgery. So we have to look for the respiratory mechanics, gas exchange, pulmonary interaction. These three forms a three-legged stool test. So respiratory mechanics from the FEV1, it has to have post-operative predictive value more than 40% at least. Cardiopulmonary reserve VO2 max should be more than 15 ml per kilogram per minute, or a stair climbing of 2 flights or 6-minute walk test should achieve around 400 meters.
Can you summarize? Can you summarize?
Yeah. So I will show all the tests. See, these are the battery of tests we have in our armamentarium. One is the pulmonary function test. We all get the FEV1 values where we can know it should be at least above 40% for a major lung resection. DLCO, diffusion carbon monoxide, shows the capacity of the person gas exchange at the alveolar level. There are 6-minute walk test, 12-minute walk test. A CT can give us a volumetric analysis of the
order
lung.
of doing testing? What is your order of evaluation, rather than going into details?
Yeah, so depending on the patient, whether it is already metastatic at present or initial
surgical patient, fitness for surgery.
Yeah, fitness for surgery, basic lab test, a pulmonary function test with DLCO, and 2D echo or a dobutamine stress echo should always be done for these patients.
Any questions?
So no single respiratory test has given adequate value.
Stop here for this moment, because some discussion should also be generated. Yes. One important point I say, because you see, as a patient who is presenting, who is potentially operable lung cancer in a government setup, if these things becomes too complex, the process of getting the fitness evaluation done may also take a lot of time and make the patient inoperable. So what do you suggest should be the immediate focus if I find a patient who is potentially operable in a OPD? Because that is what is chest physicians, generally they see TB. Yeah. So then one potentially operable case, we may not miss the time. Yes. So we should have some kind of a grade down system of doing evaluation.
So one clinical test, what I always do, I tell the patient go down on the ground floor and climb 2 flights of stairs and come to me. That is it gives me a general idea whether this patient is fit or not. We can do a 6-minute walk test, which is easily available and can be done on OPD basis.
So that is about
Yes.
fitness. What about operability? Do you think PET scan should be done as
PET
soon as?
scan, definitely PET scan is the mainstay of our lung cancer diagnosis and management, where we have to know that it is not a metastatic disease we are dealing with.
We can allow one more question from the floor. Floor.
Yeah.
It is a very important topic. Yeah,
Yes.
there's one. Yes.
Yeah.
So we did a PET scan. PET was negative actually.
Yeah.
SUV was 1.5, and there is no high risk factors. Only patient was 65 years. No other high risk factors. How can we manage this? We tried a biopsy. Biopsy was actually not possible. It was so hard nodule. So how can we proceed with this?
Yeah, as discussed by Dr. Devyani, 8 mm nodule, either you have 3 options. You can observe it. If it is a highly suspicious, then if you are biopsy is not possible, you can take him for a VATS, wedge resection, and proceed frozen section, and then proceed for the definitive management.
So even though the PET is negative, whether we should go for a wedge? Even the PET
Even
is
if it
also
is PET
negative.
negative.
Yeah. The physical characteristics, you have to look at the speculated margins and his things. Sometimes adenocarcinomas might be PET less evident.
So imaging wise, it was not having any features of malignancy. That is why I am asking.
Yeah.
Finally, what happened? We were gone for a wedge as the patient insisted, and it came as adenocarcinoma, which was stage 3A. Finally.
It happens, you see, a matter of judgment has to be there always, that what can be cancer and what can, because we have hematomas, tuberculomas, everything is there.
Dr. Sabita has to say something.
Sabita.
So it's not only the imaging characteristics, how it looks, it's also the history of smoking, the age. Anybody who is more than 60 years has a higher risk of malignancy than somebody, say, who's 40 years. If they have ever smoked, even if they have quit smoking, they have a higher risk. And then you look at the imaging. And like Bhushan said, a lot of adenocarcinomas, especially with the lipidic pattern, AIS, they may not have any uptake on PET. So if you have a fair degree of suspicion, and if your patient is fit for a short GA procedure, you should go ahead and take a wedge.
I think we stop at that. This is an endless discussion. Dr. Bhushan, we are actually sorry, the major part of your talk could not be discussed about fitness of this thing, but time we have to adhere to. Thank you so much for your talk. Thank you. And may I have the pleasure of inviting Dr. Sabita now for a talk on management of early lung cancer. I think that will also throw light on some of the questions raised just now. Thank you. Please, Dr. Sabita.
Good morning, everyone. At the outset, I would like to give the organizers my thanks for giving me this opportunity. It's always a pleasure to come back to NITRD, and thank you, Pallavi and Dr. Devan. So I'll be talking on management of early lung cancer, and this encompasses a lot of things which have revolutionized treatment of lung cancer in the last 5 years. Obviously, I will not be able to cover the non-surgical part, and Bhushan has made my job easy by talking about staging and fitness. So we are going to discuss these few topics which are pertaining to early lung cancer, and we all know that it's the leading cause of mortality worldwide, more mortality than the next 4 common cancers combined, and mortality parallels the incidence. As Bhushan pointed out, the prognosis of stage 1 and 2 lung cancer, which constitutes early lung cancer, is extremely good, and this is even getting better day by day. So why surgery? How do we decide that the treatment of early lung cancer should be surgery? Surgery has been the treatment of choice for the last 7 to 8 decades. Even though there is no randomized evidence available as of now comparing it to another modality, it is established and clinical staging is inaccurate, so we need pathological staging, and the way to get it is to get the lung nodule out. There are other alternatives which are coming up, but like we've seen with the LCAP data, that survival in stage 1 lung cancer can achieve rates of more than 90%. So this is how surgery for lung cancer actually evolved, with Graham doing a pneumonectomy in 1933, and we have come a long way since then. So we have to stage the mediastinum. That is the primary goal. But in early lung cancer, especially in a nodule which is less than 3 centimeters, you can forego invasive mediastinal staging. Now, if I go into the details of mediastinal staging, that is a topic for another talk. So I'll straight away jump to surgery for early non-small cell lung cancer. Surgery encompasses removing out not only the primary, but also addressing the lymph nodes. And there are various procedures which you would choose according to the tumor, according to the patient's fitness, and what your expertise is. So how do we determine the extent of surgery? This is a seminal paper that came out in 1995, a randomized controlled trial which was conducted by the Lung Cancer Study Group, where they randomized close to 300 patients with T1N0 lung cancers. And remember, at that time, there were no PET scans. So they had determined this staging on X-ray and CT scan. And they compared this group who underwent lobectomy to those who underwent wedge or sublobar resections. I don't know if the definition of segmentectomy was very valid at that time. And they saw that these patients who underwent limited resections had 75% increased recurrence, 50% increased cancer deaths, and 30% increased overall deaths. So this established lobectomy as the gold standard in 1995. And since then, it has been the unparalleled type of surgery that most lung cancer surgeons would offer to their patients. At the same time, when people were refining their lobectomy techniques, there was a growing interest in sublobar resections. And why was this happening? Because the epidemiology of lung cancer was changing. The cigarettes that people were smoking, the filters used, everything was changing rapidly, and this was leading to detection of more and more peripheral adenocarcinoma rather than the central squamous carcinoma, which was seen in the 70s and 80s. Wider availability of CT scans, also aging population which was presenting with early lung cancer with no reasonable alternatives to surgical management. Also, the morbidity with lobectomy got people thinking, can we do something less and achieve the same results? When the National Lung Cancer Screening Trial was published in the early 2000s, we saw that the survival rate that could be achieved with stage 1 lung cancer was more than 90% if we subjected them to surgery. So this was a paper that actually changed a lot of things. It came 10 years, exactly 10 years after the Lung Cancer Study Group trial, and it looked at 15,000 patients operated in the US, and they were age grouped. And when they looked at patients above the age of 71, there was no difference in survival when you offered them a segmentectomy. After that, there was a slew of publications from all over the globe, China, Japan, Korea, US, Europe, everywhere. And they started comparing lobectomy to smaller resections. So some papers said the survival was better with lobectomy. There was a meta-analysis which said survival was similar to lobectomy if you did a segmentectomy, and others looked at the size criteria and said that for tumors less than 2 centimeters, segmentectomy was equivalent to lobectomy. Based on these two meta-analyses, researchers and lung cancer surgeons all over the world got thinking, and they said we have to generate evidence if we want to treat these early lung cancers with some amount of smaller surgery. So this was the trial that came out and created a lot of media attention. A phase 3 non-inferiority trial from Japan comparing segmentectomy with lobectomy, the largest surgical trial that has been done in a long, long time with more than 1,100 patients. And they saw that segmentectomy was actually performing better than lobectomy when it came to survival. Even though the local relapses with segmentectomy were twice as that much as lobectomy, after a follow-up of 7 years, the survival was still better for segmentectomy when they compared it to a lobectomy. Although it was designed as a non-inferiority study, this study has been called the trial of the decade because it ended up showing that a lesser resection could actually offer better survival compared to the gold standard that was lobectomy. Following this, close on the heels, came a comparison between lobectomy and sublobar resection, which included segmentectomy as well as wedge resections. This was an international study with centers from the US, Canada, Australia, randomizing close to 700 patients, and the perioperative outcomes in both groups were similar. No difference in survival, even after a follow-up of 7 years, and this has really set the stage for recommendations for segmentectomy to be adopted as a procedure of choice when your tumor is less than 2 centimeters. So, is segmentectomy ready for prime time? At least in India, less than 1% of our patients will present in stage 1. So, if we have to perform segmentectomy, we are not going to get a regular flow of patients to overcome our learning curve. That is something that needs to be kept in mind. we have to plan these patients accurately before surgery using reconstruction software, which is quite sophisticated and not widely available. You need to have access to intraoperative frozen, sample your lymph nodes meticulously, and also determine which segment is to be removed by using adjuncts such as ICG and other techniques. There is a steep learning curve with doing a segmentectomy minimally invasive, and air leaks after segmentectomy can be troublesome. So is it ready for prime time? Not yet, is what I would say. It is only indicated in peripheral lesions and less than 2 centimeter tumors. After we look at this early stage lung cancer, there is still the central early stage lung cancer that we see in heavy smokers, that we still see in this part of the world. And here also, parenchyma preserving approaches are proving their oncological equivalence. Localized tumors which arise at the origin of a bronchus or a branch of the pulmonary artery, and in patients who are not fit for pneumonectomy, is where we would offer these procedures, which are known as sleeve resections. And when we compare the complications and the survival, the complications are not very high compared to pneumonectomies. In fact, they are better, and survival is equivalent. So we are not doing the patient a disservice by saving their lung parenchyma. So what constitutes adequate margins? You may do a lobectomy, you may do a segmentectomy, you may do a sleeve resection. But finally, the oncological principle that you have to adhere to is to get a negative margin. So when you do a lobectomy, when you dissect along the fissure, that anatomical margin is your adequate margin. In segmental resections, we follow the intersegmental planes. But however, we still have to get a frozen in these cases. For wedge resections, you have to get a margin which is equivalent to the tumor diameter or at least 2 centimeters. Bronchial and vascular margins, earlier, in fact, they were said that you need to have 1 centimeter margin. We are moving away from this, and now a negative margin is good enough. So this was a meta-analysis which looked at the surgical margin, whether it affects recurrence and survival after sublobar resections, and they said at least 10 millimeter margin is recommended after sublobar resections. There are various methods of measuring these margins when it comes to sublobar resections such as segmentectomy and wedge, but that is another talk for itself. So after you've removed the primary, you have to look at the lymph nodes, and there have been many studies, some large trials like the ACAZOG Z0031 trial, which had more than 1,000 patients, and a meta-analysis which looked at all these trials put together said there was no increase in operative morbidity, there was better clearance and prognostication of the patient, and also the survival was better. So most guidelines now recommend systematic mediastinal lymph node dissection over sampling. So while we were moving away from doing a lobectomy towards a sublobar resection, lymphadenectomy has also started moving away from clearing all the lymph nodes in the mediastinum to doing a lobe-specific lymph node dissection in smaller tumors. A lot of papers from Southeast Asia, where they have a strong screening program and they see these smaller tumors, and then they feel that why should we go ahead and remove all the nodes when removing only some specific nodes will do the same job. So a lot of Japanese studies and Korean trials where they have divided lobe-specific lymph node dissection into lymph node sampling versus lymph node systematic dissection according to the lobe where the tumor is, and they have seen that it's oncologically equivalent and safe. Again, another meta-analysis which addressed the same issue, and they said sampling is inferior, and even when you're doing a lobe-specific nodal dissection, go ahead and clear the entire template. So fair enough, we have to remove the tumor, we have to remove the lymph nodes, we know how to do it, but what approach would we use? So the posterolateral thoracotomy has been the workhorse of the thoracic surgeon for many, many decades now and continues to be so. But while we are all moving away from larger tumors, from bigger surgeries, we are also moving towards smaller incisions, and this can be achieved by using either video-assisted thoracoscopic surgery or the robo. And video-assisted thoracoscopic surgery, whether it is multiportal or uniportal, is not something new. I'm sure most of us are doing most of our resections using VATS now, and it has proven its mettle by giving us less postoperative pain, earlier recovery, better functional, better cosmetic outcomes. It is equivalent oncologically, and sometimes it may give a better lymph node yield. Coming to the randomized evidence for this was published in January 2022, Eric Lind's trial, where they looked at thoracoscopic versus open lobectomy, and they saw that the functional and the immediate postoperative outcomes were much, much better with VATS, even at the end of 1 year. Coming to robotic lung resection, This was a paper from Surfolio, the largest series, which was published in 2017. Really impressive results, something that we should all aim for, the textbook outcomes after lobectomy, and several other series which have shown similar outcomes, but cost is the biggest barrier to the uptake of widespread robotic lung resection. The trends in the US at least show that there is an exponential rise in the use of the robo for lung resections. Whether it will follow the same pattern worldwide, we still don't know. So after you've done surgery and you have a good survival, you want to maximize this, you want to improve this even further. So you need to combine it with a lot of multimodal agents which are coming up in early stage lung cancer in a big way in the last 1 decade. So early stage lung cancer, typically you would choose tumors which are less than 5 centimeters and do not involve the mediastinal lymph nodes. But if there is an incidental N2 node, or if your tumor is more than 4 centimeters, you should offer the patient adjuvant chemotherapy. If your margins come positive, if you can revise, please go ahead and go revise with surgery. If not possible, if the patient is not fit, then the patient deserves adjuvant chemotherapy and radiation. Osimertinib and immunotherapeutic agents are coming up in a big way, and this is associated with a major PAT-CR. So in the last 3 years, 2 to 3 years, there have been 4 landmark trials. In the adjuvant setting, ADAURA, which looked at adjuvant TKI in resected EGFR mutated patients and showed us an impressive DFS with a hazard ratio of 0.17, 83% improvement in disease-free survival, unheard of in oncological circles, but we still don't have OS data for this. The Empower 010, which looked at adjuvant immunotherapy and other neoadjuvant studies. So all these studies have actually shown better prognosis, better results in larger tumors in stage 3, and whether this is really applicable to stage 1 and 2 remains to be seen. And we also need alternatives to surgery because not all patients may be willing, not all patients may be fit. And the front runner in this is the stereotactic body radiation, which is less invasive, gives equivalent targets in medically inoperable patients, has some side effects but not as bad as surgery. Comparing these 2 techniques has been challenging, and the pooled evidence from the 2 randomized trials, which could not accrue completely, showed that it is equivalent to surgery, if not better. So my take home, surgery is still the original targeted and personalized therapy where we personalize the treatment to the tumor and to the patient. Lobectomy is still the gold standard for surgical treatment. Segmentectomy and sleeve resections are justified in selected patients and high volume centers. MIS offers better short-term outcomes. Systematic mediastinal lymphadenectomy, if you can offer it, and multimodal approach is promising, but long-term survival is awaited. Thank you so much.
Thank you.
I think you have done a great job of summarizing absolutely important points so well and all this. And if I can ask a question, when you were mentioning about this KIMS data about the comparison between open and VETs, the points which are written was that the air leak and bleeding is more in minimal access.
More in minimally
access.
yes,
the overall results are better, but
overall, at the end of 1 year, they have looked at functional outcomes, pain and recovery, return to their original function. And at 1 year, it continues to be better in the VATS arm. But as is typical with all minimally invasive surgeries, you are only going to get better post-operative outcomes which last for a short time. Oncologically, I don't think it is going to prove to be superior because it's essentially the same operation which you are doing through a different approach.
At least not inferior. If it's
At
not
least
inferior,
that's
good. That's good enough.
That's good enough.
That's good enough.
And in a particular set of population of older age group, it matters a lot. That's
yes,
what
it does.
Any other questions from the hall?
I have a small question.
Yes,
For the
sir.
sublobar resections,
Yes,
what
sir.
is the lymph node resection? How do you plan it out? Because the interlobar nodes are very difficult to pick up in that context.
Yes, so when you are planning a segmental resection, first of all, you need to plan your scan well. When you do a 3D CT scan and you do the volumetry of the segment, also look at the lymph nodes. They can tell you at each branching of the bronchus as well as the vessels where the lymph nodes are situated. You start with dissecting your N1 lymph nodes and the interlobar lymph nodes. If those come positive, then you have no business doing a sublobar resection. When you are doing a sublobar, remove all the lymph nodes along the segmental bronchus and the artery. So that is very, very essential. And in the studies, in trials in Japan, they actually sent these nodes for frozen. And if they came positive, they converted it to a lobectomy. I know Pallavi is waving from there.
Yeah, Pallavi wants a question or something?
No, she wants a
I want the next.
Pallavi is only the timekeeper. Okay, thank you.
Thank you,
Dr.
Pallavi. Wonderful job.
Thank you. See, absolutely, we have a very difficult time. The talk was extensive, and we have to maintain the time limits also. And now I'm inviting the Bhishma Pita, we can say, of the oncology surgery in the chest, Dr. Ramakant Deshpande sir. We'll request you to please share your thoughts about surgery in loco-regional advanced carcinoma lung.
Thank you very much. It's always a pleasure coming back to this institute because I really admire this institute for the human work that it's doing. Thank you, Dr. Diwan, Dr. Harit, very good friends. Dr. Babatosh sitting here. Wonderful to be here. My topic is surgery for loco-regionally advanced cancer of the lung. I think Bhushan, Devyani, and Savita all have made my work a little easy because they are all actually primed this whole topic so well. If you really see the aims of surgical treatment in lung cancer, for irrespective of whatever we do, is why do we do really surgery? Surgery is the best known curative treatment even today, till something comes and displaces it, in which case this crowd will completely change. To achieve a post-resection R0, microscopic clearance completely, to prevent recurrences by good techniques, radical arm-mass excision, don't vitiate the field, etc., with minimal or no morbidity or mortality, and to maintain the quality of life, whether it be it a VATS, robotic, open surgery, or whatever it is. How different is it surgery for loco-regionally advanced lung cancer? Is it really different? Yes, it is different because most of these patients will have received some kind of a neoadjuvant therapy, be it chemotherapy, radiation, and now with the trend of targeted therapy or even immunotherapy. So they are already primed, so it may have some different kind of tissue. Your patient is going to respond a little differently. They will have to have extensive investigation, including MRI of the partner. You know, MRI is not something which we do routinely, but this is something which is done if you really take a statistical analysis. Loco-regionally patients, advanced patients will have more number of MRIs. And then fitness investigations, which I think Bhushan spoke a lot about it. CPET is something which is done quite frequently in many of these patients. What we actually do for all investigation is we just simulate the body's condition into a high risk kind of a thing, as if you have already done a resection, and see if the resection is possible to be done in that patient, divide the patient into high risk, medium risk, or low risk. If you find it's very high risk, then don't go all the way at all. So you select your patients very, very carefully. You also need excellent setup. Whatever I'm going to talk about now, most of those people who are more than experienced, more than 10 years, will have seen it. Many of you will have done this particular surgery. Whatever advances what we see in the last 30, 40 years, all of you have contributed to this. So that's exactly what you're going to see it again. Now, these are the situations, surgical situations, that what you are going to see, starting from, chest wall involvement, right from the apex down, chest wall, etc. Then the bronchial sleeve resections where you want to conserve the lung, which would have been taken out earlier. Canal resections are there, chest wall involvement is there, diaphragm involvement, pericardium. One by one, I'll just touch upon this. Each one of these is a topic by itself, but I'll just touch on that. Why do we do really this surgery? What do you mean by loco-regionally advanced? It's stage 3 cancer, most of them. So 3A, the clinical stage, you can see here that in spite of all this, you can still get a decent kind of a 5-year survival rate. Almost 1 in 3 patients can actually survive if the mediastinal nodes are not involved. Let's start with Pancoast tumor. It's the uppermost part of the lung, which is involving an adjacent portion of first or second ribs. That is generally the Pancoast tumor. Maybe the lowermost part of the brachial plexus. Occasionally a blood vessel which is involved. If the celiac, if the ganglion, stellate ganglion is involved, then you can get a syndrome. So the Horner syndrome. So this is the Pancoast syndrome, and that can be actually be treated fairly well. And this is what I was talking about, that the MRI will actually differentiate patients. So actually this will help you differentiate between those patients who should be operated and those patients who should not be operated. Anything which goes above C6, if you take it out, your hand goes. It's completely useless hand. So that is the time when you are going to stop. And this is an investigation which actually will help you differentiate about it. The approaches are many. I think Dr. Santosham will speak about this later on today in the afternoon. You can either go anteriorly or posteriorly. Remember, again, the aim of the treatment is to achieve an R0. And along the way, if you need to replace a vessel, that's what you will do. If you need to excise a lower part of the brachial plexus, that is all you will do. And again, most of these patients will have received preoperative chemoradiation therapy, and only then they will do well. There are various type of incisions which actually it is almost an imaginative kind of an approach in multiple ways. What you can see here, the idea is very clear. Approach the primary, approach those ribs, approach those vessels, so on, and that is exactly how we will do this particular thing. This is the most favorite incision which we use in our setup. This is known as Masaoka incision. When you put an incision through the supraclavicular, midline sternum, and then go again laterally, the entire chest wall opens up like a book, and you can take out everything, unless you have to actually excise the entire vertebra. That is the time this becomes a little easier. If the vertebra is not really involved, then whether you take anterior or posterior incision does not really make much of a difference. Why do you do this? Because there are overall 5-year survival rates with preoperative radiation and surgical resection is 30%. Patients with uninvolved lymph nodes can go beyond that. Patients with incomplete resection, mediastinal node involvement, or T4 vertebral invasions, less than 10%, so best not offered this particular thing. All said and done, 2/3 will still have a recurrent disease over a period of time. Poor prognostic factors are presence of Horner syndrome to start with, extension of tumor into the base of the neck, great vessels involving the vertebral bodies, involvement of mediastinal nodes, etc. This is something which has been done, and you can see there that that small white thing is a replaced subclavian artery. This is now, if it extends, if the disease extends, it can actually involve the vertebral bodies also. You can see here that the vertebral body has been excised along with doing an excision for a Bancroft's tumor. So even that you can do. So what I mentioned is, when you have to prepare for these patients, it has to be a multi-consultant kind of a conglomeration which needs to decide about this. So you need to have your neurosurgeon, your pulmonary physician, and so on and so forth. So these surgeries cannot really be taken very, very lightly. You can see here that that vertebral gap has been actually been replaced by putting a contraption there. You can see there that is called a cage, and that replaces the body so that there is no collapse or there is no paralysis. Done properly, this is a reasonably straightforward surgery, but it can take up to 6 to 8 hours. So when lower down, the chest wall actually has to be excised along with the primary of the disease and part of the vertebra. These constitute about 5% of resections. These are long surgeries taking anything from 6, 8, or maybe even 10 hours. If only the posterior part, you can see here that there is only a posterior transverse process and the tubercle has been involved. Not much of a body has gone in this particular patient. So that's a type A resection. Type B would be 50% of the body and a unilateral kind of a half is actually involved, where you can excise or may or may not be fixing that spine based on what your spine surgeon feels. Type C is over 50% involvement and bilateral, but that is both sides of the vertebra are actually involved, which becomes more difficult. You have to fix those spines. Survivals for these kind of things, immediate postoperative, is if it's an R0, then it's about 61 to 74%. If you have to completely, which means that it's a complete excision and replacement, it's almost about 100%. The unfavorable factors for survival is a positive microscopic disease in the patient, sublobar resections, response to neoadjuvant treatment, which is poor, and age after 70 years of age. You can't really do that thing. If you are looking at only chest wall involvement, this is reasonably straightforward. Somehow in our clinical thing, people coming from Northeast and from Nepal, we found that they are the people who have a lot of these kind of diseases. I'm still not very clear why exactly it happens. But if you really analyze our data, 80% of our patients who have undergone chest wall excision are from that geography. Always you do go ahead with your primary excision, whatever you have decided. Most of these patients are lobectomies. I don't really remember doing a pneumonectomy for this. constitutes 5 to 10% of our resection. T3, N0, M0, 5-year survivals are almost above, almost up to 50%. The moment it hits the mediastinal nodes positive, practically, if the lesion is more than, because these patients become locally as well as regionally too advanced to offer a curative thing. So the significant factors are age, again, extent of lung resection, and if the mediastinal nodes are positive, best not to be too heroic for these kind of patients. The reconstruction is, you can use anything that you want. You can use a mesh, you can use the strips, whatever you get, or you can use, there were earlier days we used to use the fasciolata itself. Anything which stabilizes the chest wall is most welcome. We come to the loco-regionally advanced kind of an intrabronchial kind of a disease. It could extend either into the trachea, it could extend into the bronchus. These are bronchial sleeves. Sleeves are basically circular sleeves of the respiratory tract which are excised. For example, it has been shown here. This is a very classical thing. And from this point of view, doing a proper investigation is very important. You can see here that when you do a 3D reconstruction, you can see that the distal runoff is available, and that is how you plan your surgery. The technique of operation is very important. You need to actually do a absolutely point-to-point reconstruction of the respiratory tract. Otherwise, if you have air leak, then you will have a major kind of a problem. Multiple types of sleeve resections are possible. You can do a lobectomy with taking out the main cylinder of the bronchus and then reanastomose either in the upper lobe, lower lobe, left side, right side, whatever you want, and you can restore the function of that particular patient. How do you do it and what are the results? I could come across this 145 patients in Netherlands followed over a 10-year period. Median survival was about 52 plus or minus 10 months. Significant factors were nodal stage and patient age. Again, if you see 5-year survival in nodal negative patients were 62, 10-year was 55%, N1 is 29 and 21%, and N2 is 31 and 6%. So the moment it hits the node, you have a problem. We come to the carinal involvement. Many times you have a carcinoma of the main bronchus going into the carina. You do chemotherapy, you do immunotherapy, the disease regresses, and you find that there is a 1 centimeter level available. Don't fall for it. You have to resect that carina as per the original picture. And that's how you can actually improve your survivals. You can actually recreate the entire carina itself, or you can keep on doing anastomosis right to left bronchus directly into the trachea, and so on and so forth. Don't create acute angulations. Don't allow any air to leak. In T4N0, 5-year survivals of almost 50% you can get, and these patients would have just received chemoradiation therapy, and their survival would never have been equivalent. T4N1 is 32%, and T4N2 is about 12%. Again, T4, the moment you have mediastinal nodes positive for a T4 lesion, best is to avoid resection. Those are anyway classified now as 3B. Primarily, they would not qualify for surgery. As an exception, you can still do it. If it's an adenoid cystic carcinoma, you get a 62% 5-year. N0 squamous cell carcinoma is 46%, N1 32%, and N2 again 12%. So important factors in this is airway management during the time of surgery. The bronchial blockers are wonderfully useful, and you must have a very, very good anesthetic team for these kind of surgeries. You can extend the bronchovascular, this thing to almost a vascular sleeve also. You can see here that the vascular sleeve also is being actually anastomosed. You can do that. You can put a patch on the superior vena cava if the disease extends there. And this was actually done on the spot using a pericardium of the same patient. So you can do a lot, but mind you, do it only if you can achieve an R0 resection, which means that all gross disease from the site has to completely disappear. Something that you always think in terms of doing while operating a patient for a mesothelioma or any kind of a solid tumor. And the benefit, you can see here that you can almost get a normal chest X-ray here. Survivals are not really that bad at all. remember, if it's a node negative disease, go all out with a good kind of a team. Pericardial involvement, you can see here that pericardial involvement can come in three forms, either only pericardium with a pulmonary vein, or even the atrial kind of an involvement, and maybe an extending kind of a thrombus. So you prepare for the war very, very diligently with all kind of an imaging. If it's only pericardial involvement, it's like all these particular three varieties come in 1/3, 1/3, 1/3. 5-year survival is about 15%, 10-year survival is 10%. Otherwise, it will just be a 0% survivals. So the frequency of pneumonectomy, R1 or R2 status, N1 or N2 are poor prognostic factors, so don't chase those if they are metastasis. Lung cancer involving diaphragm, we see this quite often. If you really look into the literature, the number of cases, you don't really find that many. That cannot be true. Because I'll tell you, any thoracic surgeon who's sitting here will have operated at least a few patients who will have had diaphragmatic involvement and will have excised and not published that data. So it happens more often than not. Arm mass excision is the key to everything. Reconstruction by plication, mesh, or even fascialata, as I mentioned. If R0 is there, then about a quarter of them will survive. But if you scrape it, if you scrape the disease, you are not going to get any survival after 4 years. If only parietal pleura on the diaphragm is involved, 33% will still survive. Full thickness is almost about 1 in 4. The superior vena cava sometimes needs to be resected. This is a far safer operation done than what it appears. It appears very major, but even without a bypass, you can actually do this. 1% of overall resections are like this. 72% are for the primary disease, and about 28% are for nodal considerations. Complete replacement in about quarter. Partial resection with suturing, where it gets narrowed in about half. Vascular stapler in maybe about 1 in 6 or something, and a patch like what we showed just now in about 7 to 10%. You have a mortality rate of 10 to 12%. 5-year survivals are about 20, 21%. Median survival is about 11 months. Very rarely, if it extends, then you need to do an atrial resection. This is, you almost always need a cardiovascular surgeon for this kind of a surgery, unless you are experienced in this yourself, as by your exposure to cardiovascular residency or something of that sort. Please do not venture into these surgeries if you don't have that backup, and the backup of a bypass also has to be there. Postoperative morbidity is about 52.6%. Mortality is almost about 1 in 10. Adjuvant therapy becomes very, very necessary for these kind of patients. As Sabita was saying, whether you do these surgeries by an open or whether you can do it by minimally invasive, either VATS or robotic, is a matter of conjecture. It depends upon your comfort, but mind you, you can actually do every single thing that I have said by minimally invasive today. It's more expensive, but for all the postgraduate students today, you must know minimally invasive. 10 years down the line, not more than 20% of these surgeries will be done open. 20 years later, probably about 95% will be done by minimally invasive. So you want to survive as a surgeon 20 years down the line, you have to know these kind of techniques, uniportal or multiportal, whatever it is there. Benefits are there, special instruments are coming up, looking at the articulations are getting better every day, the vascular instruments are getting better, robotic surgery is improving. So how you do it is not very important. Get into this and then choose your patients very carefully, set up your team and go ahead. All the best. Thank you.
We'll take a couple of questions.
It is always pleasant to be with Raman in any audience, and we love each other very much.
Thank you.
So if I recollect my experience of 15-20 years, in the early part of this century, there have been quite large number of extended resection, these locoregional cancers. And after that, when aggressive chemotherapy, radiotherapy came in the picture, there has been a lot of confusion among surgeons and oncologists. I want your take-home message for everyone sitting here. In the age of aggressive chemotherapy, radiotherapy, combination therapy, and this surgery, where do you stand now?
See, the preoperative treatment is given for two reasons. Borderline operable patient is made into a resectable one, that's number one. Number two is we presume that it will actually reduce the incidence of micrometastasis and help improve the overall survival. Whatever improvement in survivals comes because of micrometastasis control is very, very minimal, maybe 1% or 2% difference. That is all that is going to happen. Improvement in the resectability is something which is visible. You can find that, but your field of resection must retain your original plan. You cannot really avoid that because you will get a recurrence at your margin of resection. So if you feel that a patient is not likely to tolerate a preoperative chemotherapy and then become fit for surgery later on, better avoid that preoperative therapy and go ahead with surgery directly. So that is exactly what policy we follow.
Can we say it this way, sir? If the lesion is resectable and mediastinum is not involved, then we should go ahead.
Yes, we should go ahead.
Go ahead.
Yeah.
That's what
Thank you, Raman. Sorry we missed you in Chennai. One thing that I wanted to tell is your last part of it. I think we have to progress, we have to know newer things, and we have to encourage our youngsters to learn them. Down the line, I'm sure most of the surgeries are going, but at the same time, the person who's learning newer non-invasive, minimally invasive procedures must also know how to do open surgery, because time and again it may be necessary. And another thing is, initially it takes time, but as you go on learning, the time in fact becomes lesser. That's what our observation has
Absolutely.
been. Thank you.
Absolutely.
Thank you. Last question, yeah, Dr. Bal. Yeah.
So I just wanted to ask you about your experience with neoadjuvant immunotherapy before going for surgery.
It's the new kid on the block. Actually, it's come up only for last 2-3 years, to be very honest. I have a few patients of cancer lung, not in this situation, but who have actually responded so beautifully that there is no residual disease. It's a complete response that what we have found in when you combine chemotherapy and immunotherapy, provided you have PD-L1 more than 50%.
So is it chemo, radio plus immuno or immuno alone?
No, not radio, not radio.
No.
Not radio.
Thank you.
Thank you
so much.
Thank you.
Thank you.
So, do we have the recorded talk by Dr. George now? We can start. Dr. George, is the very senior oncosurgeon from Bombay, Tata Memorial, but right now he's
Nanavati. He's not Nanavati.
Now he's at Nanavati. Yeah. Dr. George, we have a recorded talk. He was to be present here.
Good morning, everyone. First of all, let me thank the organizers for inviting me for this talk here. And secondly, let me present my profuse apologies to Pallavi and team for backing out at the last minute and thank you for allowing me to present this online. And my sincere apologies. So today I'm going to speak about the management of local regionally advanced lung cancer, the best evidence approach. So let's start off with the definition of locally advanced lung cancer. We are all very clear as to what is early stage lung cancer. It's basically T1 or T2 or N0 disease. So it's very clear. And metastatic disease, obviously, that's anything but distant metastasis. Now, what is local regionally advanced disease? It's basically everything else, which means that it's a very heterogeneous group, which includes T3 and T4 disease, along with various types of N2 and N3. As many subgroups involved and very heterogeneous groups. So how do we manage this is the question. Now, the importance of management of local regionally advanced disease is that it presents a significant proportion of patients present with local regionally advanced disease, probably around 30%, roughly around 22% only with N2 and N3 disease. And the survival is obviously a little bit worse than early stage disease, but significantly better than metastatic disease. And this is only possible through multimodality management, which is the key to curative treatment of local regionally advanced disease. Surgery, of course, plays an integral role in the management of local regionally advanced disease, but we have to be sure about how the sequencing of management is done, as in where to place chemotherapy, radiotherapy, and surgery in the ballgame. So, what do we have evidence for? We have great or significant amount of evidence from randomized trials in the management of mediastinal lymph node involvement. So we know for sure almost how well to manage N2, N3 and different subsets of N2. However, when it comes to management of T3 or T4 disease, which is basically a surgical arena, the data is or the evidence is quite sketchy. Now, when we see lesions like this, which are clearly resectable locally advanced disease like T3 at chest wall, T4 diaphragm or the vertebra, or T3 bronchus, or even a pancreas tumor, we know that they are all clearly resectable and the patients do well. But if someone asks you, is it significantly better than chemoradiation? Somehow we do not have the data to offer a clear answer. Now the picture is even more confusing because along with all these D stages, the confounding picture is the presence of N2 or N3 disease along with these advanced primary lesions. Now, in the presence of nodal disease is a much more important prognostic factor and predictor of survival than the primary itself. So the picture becomes even more confusing. The only speck of good news in this is our oncology friends have been working really hard at this, and in each end stage, we probably have an answer as to how to manage it best. So, for instance, we know that in a single station N2 disease, which is less than 3 centimeters in size, we know the induction treatment, either with neoadjuvant chemotherapy or chemoradiotherapy, is best. There is more evidence now favoring the use of neoadjuvant chemotherapy, and even now the Nadeem trial has come out, which shows that chemoimmunotherapy is actually significantly more beneficial than neoadjuvant chemotherapy. And surgery definitely has an integral role in the treatment after the use of neoadjuvant chemotherapy. But however, there's some controversy, which there is a practice pattern survey showed that there was a 50-50 breakup between the use of neoadjuvant chemotherapy and neoadjuvant chemoradiotherapy. So essentially, the treatment is neoadjuvant treatment followed by surgery. What happens when there is multi-station discrete N2 disease, which is something which we commonly encounter? The prognosis is obviously worse, and most guidelines favor chemoradiotherapy as a primary form of treatment. But some patients, there is a statement in the guideline which says that patients with resectable N2 disease should not be excluded from surgery because some of them may be offered long-term survival or may be cured. So it's a little bit confusing picture, but the role of surgery in this situation, multi-station discrete N2, is generally salvage if there is residual disease after chemoradiation. There is an evolving role of surgery upfront instead of radiation if the patient receives neoadjuvant chemoimmunotherapy, as is proven by the Nadeem trial. Now, the strongest evidence in nodal disease, management of nodal disease, is in N3 disease, where the Pacific trial has shown that the best form of treatment is chemoradiation concurrent, followed by durvalumab, which is a standard of care. The median survival was 47 months as compared to 29 months with chemoradiation alone. And in this case, the role of surgery is strictly limited to salvage if there is or recurrent or residual disease after offering concurrent chemoradiation. Now that brings us to the end of the management of advanced nodal disease. What about primary disease? So if you get a T3 or a T4 disease with involvement of the bronchus or trachea, the evidence is strongly in favor of parenchymal position, and this should be the emphasis of surgical management. So to avoid a pneumonectomy as far as possible, to preserve as much parenchyma as possible, of course, following all oncological principles. So whenever possible, a sleeve resection should be attempted. It improves long-term survival as well as reduces postoperative mortality. Unfortunately, there is no randomized evidence, and most of these treatments are based on large retrospective series, including one which is of nearly 2,000 patients. Other T3s, this is a commonly encountered entity, chest wall resection. We all know that the patients do very well after surgery, and again, unfortunately, no great randomized evidence. But the message would be that if possible, the surgical resection is the best option when the morbidity is not significant. That is, please do not do anything with a large 6 or 7 rib excision. Anything which is small and manageable without significant morbidity, surgery is the best option. And the reconstruction should be done as appropriate. I don't think this talk has a scope to handle various forms of reconstruction, so I'm going to leave it at that. And the role of postoperative radiotherapy is a frequently asked question. As per the current evidence proved by the Lung Art or the PORT-C trial, the only role of postoperative radiotherapy is an R plus resection. and not even in a positive nodal N2 status. The only place is an R plus resection. And of course, the patient will require adjuvant chemotherapy. What about the other T4s which we know of? What diaphragmatic involvement or vertebral involvement? The best evidence we have shows that resection, when there is no mobility, is the best option. This is particularly true in these two entities, particularly in the diaphragm, where radiotherapy may be technically difficult because of movement of the diaphragm, and also in the vertebra, where radiation of the spinal cord might be a problem. So technically demanding, and surgery might be the best option. Again, unfortunately, no great randomized evidence. The coming to the last scenario, which I could think of in a locally advanced disease, is a superior sulcus tumors, another commonly known entity. Here, the role of surgery is pretty select. If there is N2 disease or brachial plexus involvement, chemoradiotherapy is the best option. If resectable, that is without N2 disease or brachial plexus involvement or major vascular involvement, surgery is the option. But the best evidence favors neoadjuvant chemoradiation to a dose of 50 gray, followed by surgery. Unfortunately, this evidence also comes from a large series and not a randomized trial. That brings me to the end of my talk, which is a short snapshot, I should say, of the management of locally advanced lung cancer, the best evidence. I hope this was pretty clear. In conclusion, I would say that this entity requires a multidisciplinary team. This is mandatory because there are multiple modalities involved and sequencing is key. Surgery plays an integral role and an increasingly integral role because there are many situations where surgery is required for salvage after chemoradiation or immunotherapy. It is an evolving field and there are bound to be newer changes which are going to come up, and ultimately selecting the right patient is the key. Thank you very much. I wish I could take questions at the end of it, but I'm sure there are many stalwarts in the field who would be able to, who are present there, would be able to clear any doubts if there are. Thank you very much.
Thank you. I think we'll not have any questions because Dr. George is not here. So we'll move on to the last talk of this session by Dr. Praveen Yadav. He's the Chief of Surgical Oncology at Artemis Hospital, and he'll be talking about role of surgery in malignant pleural effusion. Dr. Yadav. Thanks to Pallavi. We are well in time, Pallavi, isn't it?
Good morning, everyone. I'm having a bad injury that you have to bear with my face of pain. So I will start with a very important topic that we all go through in our general practice, but the most of the bulk of the malignant pleural effusion goes to the pulmonologist, and they handle this malignant pleural effusion more than us. So as for the etiology, you know, the lung cancer is the most common cancer in the male, and it is the most common cause of malignant pleural effusion. Similarly, the breast cancer in the female is the most common cause of pleural effusion, and other hematological malignancy constitute the 1/5 of the cases, and then comes the unknown primary. So looking at the scenario, how big is the problem? Then 15% of all cancer present as a malignant effusion, and in lung cancer the ratio is 15%, which rises to 50% during progress of the disease, and in breast cancer also almost 10 to 50% of the cases sooner or later present with the malignant pleural effusion. You can say that every 6th cancer patient is having a malignant effusion sooner or later in their phase of treatment. The investigation, the X-ray is the initial investigation, ultrasound very useful and easy modality, but the most informative is the CT scan. It can differentiate between lung consolidation and pleural effusion, cystic versus solid lesion, pleural thickening and extent of the tumor. PET CT and MRI have a limited role, but PET is important in evaluating the disease response when we are giving a neoadjuvant or some therapy. We are giving a chemotherapy or immunotherapy. The aim of any treatment is to relieve the symptoms, that is dyspnea mostly, and to prevent the recurrence. And to plan any treatment in malignant pleural effusion, the prognosis of the disease and patient performance status is very important, and this is a Lent criteria which is based on the pleural LDH level, ECOG status, neutrophil lymphocyte ratio, and the tumor histology. Like that, mesothelioma, hematological malignancies are good histology group compared to the lung cancer. Then the higher the Lent score is, the more poor is the prognosis. And the similar scoring system is used for a malignant mesothelioma, that is a Bream's criteria. This is for other malignancies than mesothelioma. The most commonly used options are like observation, which is used for a small effusion, but sooner or later recurrence occurs and we have to do some intervention. Therapeutic thoracentesis is a transient procedure, outpatient procedure, which relieves the symptom immediately, but it has a higher recurrence rate. Most commonly used method is a chest tube insertion with the pleurodesis. The success rate is more than 60%, but there are side effects of the sclerosing agent. The thoracoscopy, talc porage, has a high success rate, but it is an invasive procedure. The less commonly used options are indwelling catheter, which are suitable for a local outpatient patient, but they are associated with the infections and the seedling of the tumor. Pleuroperitoneal shunts are rarely used, and the fitness of the patient is issue in these cases. Pleurectomy have a very limited role in measurement of malignant effusion, but it has a very low recurrence rate, but it is a very morbid procedure. This is a basic management protocol. The asymptomatic patient, we do a diagnostic thoracentesis. For symptomatic patient, if the survival is less than a month, then we just proceed with the tapping, repeated tapping. When we expect a survival between 1 to 3 months, then tube thoracostomy will help. And in patients who are supposed to survive more than 3 months, then we'll think of other modalities like a thoracoscopic pleurodesis and pleurectomy. So how the surgery is going to help in malignant effusion? Basically, it's help in diagnosis, staging, and palliation. For diagnosis, you see that yield of the needle biopsy when compared to the medical thoracoscopy. In medical thoracoscopy group, the yield is almost 96 to 97% in case of malignant effusion. And tissue is definitely an issue in today's oncology practice. We need a lot of ISC markers to be done and NGS sequencing for Pralinga treatment in case of malignant effusion. So the tissue we take is better in case of biopsy rather than on a cell block. What are the issues with the surgical management? Now, whether to do an open or a minimal invasive approach, whether to deal with a medical thoracoscopy or VATS, pleurodesis, whether mechanical pleurodesis is helpful or chemical pleurodesis, talc slurry versus VATS talc porage, how to manage a trapped lung and multilocated effusion, what is the role of pleurectomy and the major procedure like decortication. So this is a small study. We don't have a head-to-head comparison with the thoracotomy versus VATS, but it is a small study with 70 patients. In most of the patients, they have done a VATS, but small patient undergo the thoracotomy also, but they find out that thoracotomy is not indicated because of the poor survival of the patient, and the morbidity associated with thoracotomy is more. The spectrum of medical versus surgical thoracoscopy. The medical thoracoscopy is mostly diagnostic and somewhat is overlapping with the therapeutic procedure, but in surgical approach, we do a therapeutic procedure more commonly. This is not actual comparison within medical and VATS, but this is a data. They have compared a 231 patient with a uniportal VATS in non-intubated patient, and they came to the conclusion that in non-intubated patients, the VATS pleurodesis can achieve a similar result, but less mortality, morbidity, and hospital stay, and even the cost is less. The pleurodesis is an important component of managing the malignant effusion. The prerequisite is that lungs should be expanded, and we should have a confirmed histological diagnosis. The technique, mechanical, chemical, talc slurry, and porage, and what is the best agent. As you all know, the talc is the better agent, and in talc also the graded talc is better compared to the fine talc because the respiratory complications are more with the fine talc. Other agents are bleomycin, iodine, tetracycline. We will not go into detail of that. Now, coming to which method is better, whether to do a mechanical pleurodesis or a chemical pleurodesis. This is an article from Slovenia in which they have shown that the vascular endothelial growth factor, which is required for angiogenesis of the tumor cell, is less released in mechanical pleurodesis, and the other growth factor like TGF-1 and fibroblast growth factor are more released in mechanical pleurodesis. So they concluded that mechanical pleurodesis can equally effective than the chemical pleurodesis, and it decreases the thoracic drainage time. So it is more successful than a chemical pleurodesis. When we compare the mechanical pleurodesis with the talc slurry, and the talc slurry, they have concluded that in the pH group of less than 7.3, the mechanical pleurodesis is better than the talc slurry. And you know that low pH in malignant pleural effusion denote specify the complex effusion, that the chances of adhesions are there, and even the disease bulk is more in case of low pH group. Now, these are the important question when come that whether to do a VATS talc porous versus slurry. This is a randomized trial of 501 patients, equally randomized into the talc porous versus slurry group, and they have shown the equal result. But in the subgroup of lung and breast cancer patient, the success rate of talc porous is better as compared to the talc slurry group. And the other RCT, which is from UK, from Rahul Bhatnagar, they more than 300 patients they randomized into a talc slurry versus porous group. This is a TAPS RCT, which shows there is no difference between talc slurry and the VATS porous. Now, the important issue whether the pleurectomy is helpful in management of malignant effusion. The first evidence came in 1975 when the article come with 100 patients who underwent pleurectomy. In those cases only which failed to respond to the conservative method, and in those cases in which they diagnosed intraoperatively that there is a malignant effusion, they did a pleurectomy and showed that the pleurectomy is helpful in management of pleural effusion. And after 20 years, the evidence came about the feasibility of VATS pleurectomy in the management of malignant effusion. So whether the pleurectomy is better than tube drainage, this is a small study from China in around 54 patients. They have compared the VATS pleurectomy versus tube drainage, and they insisted that the VATS pleurectomy improves the quality of life in the lung cancer patients. But there is no improvement in survival in case in the pleurectomy patient. Other study for a mesothelioma, this is a meso-VATS trial. This is a randomized trial in which almost 200 patient trial in which they compared a partial pleurectomy in mesothelioma with a talc pleurodesis, and in this trial they shows the no benefit of doing a pleurectomy compared to the talc pleurodesis. Now the role of indwelling catheter. The indwelling catheter is usually used for lung which is not expanded, in which case the repeated aspiration is needed, and the patient who having a poor GC. The issue with the indwelling catheter is of infection and repeated complication. Other issues are like fracture and displacement. So whether the indwelling catheter is better than the surgical approach. So this is a trial in which the 109 patients they identified and they compared with the thoracoscopic talc versus tendral pleural catheter, and they have shown that there is no difference in success rate, but the hospital stay and repeated interventions are less in the pleural catheter group. Similarly, comparing the thoracoscopic pleurodesis with IPC, the same result. The hospital stay in the tunnel catheter group is less than compared to the and even the repeated thoracentesis or repeated intervention are less in the pleural catheter group. This is a ample trial which compared the pleurodesis with IPC, which is the same result. I have mentioned this trial because this is an Australian malignant pleural effusion group. Now they are conducting a ample 3 trial which is comparing a VATS versus indwelling pleural catheter, which will give the answer which is the better option. And this is ASP trial which shows that daily drainage from the pleural catheter is more effective in achieving a pleurodesis than the alternate day drainage. How to manage a trap lung, which is an important issue. Trap lung can be due to the endobronchial growth, due to the visceral peel over the lung, there is a dense adhesions and pleural base masses which can restrict the lung expansion. So the approach is whether to do endoscopic debulking, Watt's pleurectomy, decortication, or we can use an indwelling catheter which lung is not expanded, or pleuroperitoneal shunt. This is an ongoing trial in UK which is comparing the feasibility of video-assisted thoracoscopy, partial pleurectomy, decortication with the pleural catheter in case of mesothelioma. This will give an answer whether in the trapped lung we do a surgery or we'll just go with the pleural catheter. Other issues are multiloculated effusion. There is not much data about the multiloculated malignant effusion. This is a study which shows that fibrinolytic therapy used for multiloculated pleural effusion is not much effective in malignant effusion. They just improve the X-ray finding and they increases the drainage output, but they are not able to achieve the symptomatic relief. This is not for a malignant effusion, but medical thoracoscopy compared with the fibrinolytic therapy, and which shows the medical thoracoscopy is better in case of multiloculated effusion because we have a chance to break the loculations. And same article, same results, that Watt's thoracoscopy is better than fibrinolytic therapy. This is small words about pleuroperitoneal shunt, which can be done under GA or local. This is a surgical procedure which is used for, now they rarely use, I have never done it. Thoracostoma, it is a less mentioned modality, but it is very useful when you are having a badly infected pleural cavity. This is the trial of 101 patients with the pleuroperitoneal shunt. They have shown that Watt's is better, but in case of visceral carcinomatosis, pleuroperitoneal shunt is used. To summarize, the diagnosis thoracoscopic biopsy is a gold standard. For staging, it will give us an additional advantage as we can directly visualize. The minimal invasive approach is better for dealing with the malignant effusion. The pleurodesis TARC is a better agent, and mechanical pleurodesis is better in a low pH group. And thoracoscopic talc porous and talc slurry is having almost same result, but the complication of surgery and respiratory complication are more in the talc porous group. Cytoreductive surgery like pleurectomy, decortication add to the additional morbidity, but they don't offer a survival benefit. And in case of trapped lung, we can use a IPC catheter, which is a better option. And multiloculated malignant effusion, the Watt's is the better modality. Thank you.
Thank you. Thank you, Dr. Praveen. We'll take one or two questions. Yes, Dr. Pooja and Dr. Bhushan, yeah.
Very nice talk. Lots of issues to discuss and very comprehensively presented. I wanted to ask, we occasionally get patients who have had the indwelling catheters and come present with empyema, and you have to remove the catheter. Yeah, I mean, there's no straightforward answer. Any advice as to what can be done surgically for those patients? Do you take them to the OR? Do you observe them?
Yeah.
Lytic therapy?
Though I don't have much experience
Mike,
in catheter, but I have already mentioned I do lot of thoracostomas specifically for the infected pleural cavity, because it will relieve the sepsis also and drainage, and it is better to manage. I think putting a bag and the patient will manage it better than putting a catheter or large bore tube and draining it routinely. So I will prefer to go for a thoracostoma with failed indwelling catheter or infected.
So you resect how many ribs for that? Or do you not resect any ribs?
I will try to make it when we are doing a palliative, we are not expecting much of the life expectancy. I will make a small only. I will not resect more than one rib. I will just make.
Thank you.
Yes, Dr. Bhushan.
Yeah.
Yeah, it's fine. It's fine.
Very nice talk. I think so. Malignant pleural effusion is a very important topic as such, because as in India, we see a lot of these patients. So I want to ask you in mesothelioma, what is the role of HITOC?
I have done 3 so far, but I have not done an extrapleural pneumonectomy in this case. This was mostly all the 3 cases are a localized disease only, and we have resected a local resection of the visceral pleura and the parietal pleura, and then the HITOC, and we have a data both 3 of the patients are international patients, and for 2 of them, they are surviving more than 1 year. And mesothelioma we rarely see, and I don't have much. And in mesothelioma also, for surgical option, we see the histology also. Now the role of immunotherapy has come, so usually I prefer for the epithelioid histology rather than for sarcomatoid.
Yeah, I think so. With the HITOC, we can go more aggressive in future with localized
definitely,
diseases.
we don't have a level 1 evidence level 2, but definitely HITOC has a role.
Yes,
Because-
Doctor.
Just one query. Talc is excellent. There is no two ways about it. We have been doing talc for many, many decades. Except for an occasional ARDS, we have never had any problem with talc. But I'll tell you one thing, what happens is that that side of the chest actually gets frozen. The respiratory movements just totally disappear. And over a period of time, if you do the PFT, you will find that PFT goes down. So what we have done is now we have shifted completely to betadine. You know,
I have also,
yeah.
whenever I am doing a thoracoscopy,
Correct.
I have do a mechanical fluoridesis with the betadine. I never use a talc.
No, even for doing, yeah, we now given up completely talc. We have started putting only betadine. So do you have substantial experience with that? We have almost more than 100 cases now. So we find that it is not exactly as good as talc, but almost 80% there.
Sir, I think I have read one trial long back, I don't exactly remember, but they have shown that betadine is useful in breast cancer patients. They have shown that it has an equal result compared to, and from my experience, I don't have any much to say about the difference between betadine, but I routinely use betadine.
Yeah.
We also use betadine regularly.
I personally, I think what we need to do as thoracic people from India, we should document this and publish this. There is not much of literature. Why should we not get our own literature into the this thing?
Yeah.
And so let that be talked about. We, all the time, if your student just has to, survey the literature and speak, he will only speak about talc. He will not never speak about betadine and all that. So this is something which needs to come into. What about Rajan?
I have not used betadine, Raman, and we have always been using talc. And your point of poor respiratory function, I have not looked into it. Let us look into it, and then how do you put the betadine? How much of betadine?
The same way as talc.
Okay. Thank you.
Sir, my experience with betadine started because I am doing a lot of benign cases also. So post decortication infective pleural cavity.
Correct.
So for washing also, I started using betadine combined with a hydrogen peroxide.
No, but the wash is something which is aspirated. Here we leave 20 cc betadine diluted in 20 cc saline inside for this thing.
So for that also I find that betadine works well.
Works really very well. Bhushan, regarding your HITOC, we have an experience of about 7 HITOCs. One was bilateral in a patient of thymoma, where we did a decortication on one side and pleurectomy on the other side. We lost that one bilateral patient, because that lung where we had done a decortication in metastatic thymoma, it did not expand only. So we landed into such a disaster.
We landed up in a similar situation.
Yeah, it was a horrible. This was a 37-year-old lady, and I still curse myself for having exercised that.
But there is a definite role of pleurectomy and decortication, especially metastatic thymoma.
No, we did that, but the thing didn't expand, and I had done a.
Before Pallavi stands up, Pallavi, how come we are allowed so much of space? Okay. Yeah, we'll wind up. Yes.
So along with my co-chair, Professor Diwan and Professor Hari Chaturvedi.
Yes.
Sorry, I think using betadine alone has a significant failure rate. I mean, at least in our experience, I think more than 40% don't actually respond. And we found that combining bleomycin, 60 units with betadine seems to work better. The other point is about the Pleurex catheter. I have this feeling that the draining catheter is that many patients in our kind of setup actually do land up with empymas. And I think that it might be better to use a pleuroperitoneal shunt, and there is a very cheap shunt available which is made by a firm called GIS. It was actually originally used for portal hypertension by Dr. Nandi, who actually devised these 3 types of shunts. And we've used them, and it's only about 1800 rupees. And we think that a pleuroperitoneal shunt is easier. and it can be modified if it gets blocked, because one of the problems is that the peritoneal end actually gets cocooned and gets blocked.
Thank you. Yeah.
So, on behalf of my co-chair, Professor Diwan and Professor Harsh Chaturvedi, I thank the organizer for giving us this opportunity to chair this session. I just thank you all the speakers for their nice and lucid talk, covering topic from starting from the solitary pulmonary nodule to the early stage disease and the locoregional disease to pleural effusion, and the management of one topic on the management of the esophageal cancer also. So with that, we close this session and hand over the mic to the organization. Thank you. Thank you.
Yeah, with that, we now conclude the session on cancer. We would like to thank all respected chairpersons and speakers for such interactive session. Now we are moving forward for our next session. I humbly invite our chairperson to come up on a stage for next session. Dr. Lokeshwar S. Sajja, Vice President, IACTS. Dr. Mohit Joshi, Additional Professor Surgery, AIIMS, New Delhi. Dr. M. Puri, Chest Specialist, NITRD, New Delhi. And Dr. Lokendra Kumar, Chest Specialist, NITRD, New Delhi. Welcome, sir. I also request our chairpersons to give a brief about the session and the speakers.
So a very good morning to all. A very good morning to all. So the next session is a mixed bag. And to start with, we have with us Dr. Rajkumar Yadav. He is a senior professor and head of the Department of CVTs in SMS Medical College, Jaipur, and he'll be speaking on diaphragmatic hernia. So we have Dr. Rajkumar here.
Thank you, chairpersons. At the outset, I congratulate Dr. Diwan, Dr. Pallavi, Dr. Sarans, all the organizing team of this CME. And the topic assigned to me is the diaphragmatic hernia. You know, diaphragm is a dome-shaped muscular structure. It divides the chest cavity and abdominal cavity. It is right from nipple above to the umbilicus. It covers the periphery of the abdomen and the chest. It is involved in 75 to 80% of the pulmonary ventilation, normal situation. Diaphragm arises from the back of the xiphisternum, lower sixth ribs, and L1 and 2, 3 and 3 vertebrae. Arterial supply comes directly from the aorta, a superior inferior phrenic artery, and also from arterial supply from the internal mammary artery. Nerves come from C1, 2, C3, 4, 5 dermatomes and to the phrenic nerve, and venous drainage goes to the IVC, and lymphatics goes to above the diaphragm and below the diaphragm also. I divide diaphragmatic hernia in 3 categories. One is congenital diaphragmatic hernia, another traumatic diaphragmatic hernia, and one more hernia that is iatrogenic, which is created by a surgeon operating around the diaphragm. The diaphragm have some diaphragmatic hernias have some embryological basis. As you know, it is constituted of the septum transversus from ventrally and bilaterally from the pleuroperitoneal canal, and dorsal mesentery comes down, and also some contribution from the chest wall. And muscle fibers migrate from the third, fourth, and fifth dermatomes. It carries the innervation along with this. And right floor peritoneal cavity canal closes earlier than the left. That's why the hernias are less common on right side, more common on the left side. And this this whole process is finished by 3rd to 8th weeks of life. So anything after that from 10 to 12 weeks, intestine returns from the yolk sac to abdominal cavity, and by 12 weeks the fixation and rotation of intestine is over. So any delay in this return or rotation or fixation, it is early or delay, can result in diaphragmatic hernia, eventration, that may be with or without seat. Early return of intestine before the formation of the diaphragm can result in Bogdale hernia, but that will be without the sac. So congenital diaphragmatic hernias can be Bogdale, most common, Morganian, hiatus hernia, hernia through the central tendon of diaphragm in 2 to 5% of cases. Peritoneo-pericardial diaphragmatic hernia and bilateral hernia also present. Bilateral hernia has poor prognosis. You know the various hiatuses. One is Morganian, Morganian, Bogdale, hiatus. These are the foramens. So these are the normal sites. Even this hemidiaphragm is absent sometimes. So some chromosomal abnormalities are associated with diaphragmatic hernia from 18 to 26% of patients. Lung bud abnormalities, hypoplasia of the lung and pulmonary arteries. They are also associated with congenital heart diseases. Neural tube defects are genitourinary, skeletal, craniofacial defects. Gut rotation fixation abnormalities. Frey syndrome consists of digital, facial, and ear abnormalities. Diagnosis is usually made by the fetal sonography or fetal MRI. You see the extra chest of a Bogdale hernia, whole of the abdominal contents are lying inside the chest, and the mediastinum is shifted, trachea is shifted, heart sounds are shifted to the contralateral side. The prognosis, you may need some more investigation, mostly diagnosis is clear by X-ray itself, but you can go for CT scan for detail and MRI also. Prognosis depends upon the age of the presentation and degree of pulmonary hypoplasia also. The Bogdale hernia. So what is the management? Management of Bogdale hernia is very difficult one, and it is diagnosed in the antenatal life. Some interventions can be done antenatally also. But after birth, the infant neonate may be symptomatic just after the birth. So in that situation, NG tube is required to decompress the stomach and to decrease the distress. And child, infant neonate may need the intubation, ventilation. High frequency oscillatory ventilation is better than the others. Perfluorocarbon installation inside trachea and lung increases the gas. Vascular access can be gained through umbilical artery catheterization. Respiratory acidosis, inotropic support, nitric oxide to decrease the neonatal hypertension. ECMO is anticipated in this severely distressed neonates, and it is very helpful. Surgery after stabilization, there is no hurry in performing surgery immediately. Once child is stabilized well, then only surgery should be contemplated. Beware of chest tube. Chest tubes have never be inserted in these hernia cases, suspected hernia cases, because it can go inside some hollow organ and create the problem. Surgical exploration can by thoracic surgeon operate by the chest, abdomen surgeon operate from the abdomen. The contents are reduced, sac is excised, and sometimes there is a resection of external lobar pulmonary sequestration is required when it is present. Small diaphragmatic defects can be closed directly, but sometimes large defect is present. You need some foreign materials like PTFE, bovine pericardium, Dacron, Prolene mesh, etc. to repair the diaphragm. Sutures may be taken from ribs or chest wall directly when there is no remnant of the diaphragm is present. Minimally invasive method like weights is reserved for the stable child only. In sick child should not never contemplate the weights. And chest is closed after putting 1 or 2 tubes. These are the material used for repair of the. One more hernia is the Bogdelic hernia. Is a retrocellular hernia. Is more common in adulthood than childhood. Usually in the obese female, wakefulness, discomfort, cramp, obstruction may be there. And the hernia is in between the xiphisternal and the costal origin of the diaphragm. So more common right side than left side. Sake is usually present in this. These are some X-rays of diaphragmatic hernia. Yes, here, this is a hernia here. And this CT scan shows herniation of colon inside the chest. So usually they are detected incidentally. Colon omentum, stomach, small gut can be there inside. X-ray chest or CT or barium studies are required sometime for diagnosis. And open surgery is a gold standard. Laparoscopy, weights, robotic can also be done. Sake need to be resected and double layer closure is to be done. Something about hiatus hernia, there are 4 types of hiatus hernia. I think one is sliding when the esophagus is a little short and the stomach is pulled inside the chest. Paraesophageal hernia when the G junction is in the normal place, but the fundus comes out through the hiatus in the chest. The third type of hernia is a combination of 2, and fourth is one in when along with the stomach some other contents of the abdomen also comes inside the chest through the hiatus. So these are the various types of belching, regurgitation, postprandial discomfort, dysphagia, substernal fullness, gastric volvulus, intestinal obstruction, not able to swallow. These are the presentation. They are usually approached from 7th or 8th space, thoracotomy on left side, laparoscopy repair is also feasible. And 3 procedures are usually done. One is Colles gastroplasty, another is Nissen's fundoplication, and Bell's Mark IV fundoplication. This is the Colles gastroplasty, the creation of neo-esophagus, just to lengthen the esophagus, some part of the stomach is included in this. The Colles gastroplasty, it can be done laparoscopically also. The another procedure is the rolling type of hernia. The fundus is wrapped around the lower end of the esophagus, because in this G junction is the normal place, only fundus that goes inside the chest. This is a combination of 2 procedures, Colles and Nissen gastroplasty, the lengthening of esophagus along with wrapping of the fundus around the lower end of esophagus. Bell's Mark IV fundoplication when very patulous hiatus is there, and is a combination of third type of hernia when everything, both G junction as well as fundus, everything goes inside. So the diaphragmatic sutures are taken from the esophagus, from the fundus, and from the diaphragm also. And so this is the Bell's Mark IV repair. Postoperative issues in these hernias are the reflux persists in 15% of cases, and there is in this Colles-Nissen procedure more chances of the postoperative dysphagia. Something about traumatic diaphragmatic hernia, blunt diaphragmatic rupture rarely accounts for the immediate mortality, may go clinically silent until the complication occurs, which can be life-threatening. And these are various incidences reported in various literature. Mechanism of diaphragmatic injury is the high impact injuries through RTA or motor vehicle collision, fall from height leads to increase in the abdominal pressure. High level of suspicion is required. This is sometimes delayed rupture is a non-entity, more common on the blunt injuries than penetrating. Location is usually maybe on posterolateral, anterolateral or pericardial or in the from central tendon also. In children's may not have any external injury, they can come directly through the hernia. Associated injury of the spine, gut, lung, chest wall is there. Radiograph can be elusive in 50% of cases, and CT is also have the low sensitivity. Diaphragmatic hernia may not be evident immediately. This is a delayed post-traumatic hernia. Diaphragmatic hernia may not be evident immediately after tear in the diaphragm, but with time, negative intrathoracic pressure may lead to enlargement of the defect and protrusion of the abdominal content through the defect. Delay may be delay may be up to 10 years, sometime 10 to 15 years later the patient comes with the diaphragmatic hernia. Stomach, omentum, colon, small bowel, spleen, kidney may herniate in this sequence. So diagnosis is usually clinical or X-ray. This is most common entity in the young male patients. Mostly asymptomatic scaphoid abdomen, decreased breath sounds on the sun. Diagnosis by X-ray chest or some barium or CT eye oral is required. The treatment is by NG tube insertion. ICD should never be put. Patient to be put on Trendelenburg position. Laparoscopic surgery. Sir. Yes.
Thank you.
So the different diagnosis of traumatic diaphragm is hemothorax, phrenic nerve palsy, ventration, and these are some complications: chylothorax, recurrent hernia, small bowel obstruction, hemorrhage, impairment of the diaphragmatic surgery. Minimally invasive techniques, diaphragmatic repair, VATS, robotic, they are good technique, but only thing is they need a learning curve and they are costly procedures. Thank you.
Thank you, Dr. Yadav.
Yes, sir.
And in a brief, you have discussed with all the diaphragmatic hernia. And we take question in the end because we are very tight schedule. Okay.
Thank you.
I invite the next speaker. Next speaker is Dr. Anula Sisodia. Dr. Anula, please. She is Associate Professor at SMS Hospital, Jaipur, and she will speak on the topic diaphragmatic eventration and palsy. Dr. Anula.
Very good morning to everyone and respected chairpersons and my dear friends. I am going to speak on diaphragmatic eventration and palsy. There is an abnormal elevation of a portion or entire hemidiaphragm due to lack of muscle or nerve function while maintaining its anatomical attachment, can be congenital or acquired, so presenting in both the pediatric and adult population. It was first described by Pettit in 1774. In 1923, first repair in adult was done by Jean-Louis Pettit. In 1946, first repair in infant by Bisgard was done. Now, already Dr. Rajkumar has told the anatomy and innervation and blood supply. Just to summarize, I am going to say the diaphragm is a dome-shaped muscle which plays a strong role in the inspiratory phase of respiration. Also serves as a mechanical barrier between the abdominal and thoracic cavities. Innervation is by phrenic nerve C3, 4, and 5. Left and right phrenic nerves provide motor function to each of the hemidiaphragm. So any impaired development or injury to this nerve leads to diaphragmatic paralysis and diminished lung expansion. In eventration, portion or whole of the hemidiaphragm is weakened and thin, which causes decreased function. Depending on the severity, and patient can be symptomatic or asymptomatic. Etiology: congenital. Due to abnormal diaphragm muscle development, there is a defect in the migration of myoblast to the septum transversum, which causes partial or total replacement of the diaphragmatic muscle with fibroelastic tissue. It creates a thin and weakened hemidiaphragm. There is a cephalic displacement on the affected site. It is associated with other congenital disorders like Poland syndromes, malrotation, congenital heart disease, and TOSH groups of infection. Acquired. More common etiologies that result in phrenic nerve injuries and muscle atrophy. Injuries may be blunt or penetrating. Trauma may be there. Birth trauma is one significant thing, or thoracic surgery. Phrenic nerve dysfunction and illness, multiple sclerosis, Guillain-Barré syndromes, nerve compression, radiation therapy, and connective tissue disease. Paralysis of phrenic nerve damage leads to muscle atrophy and thinning of the diaphragm and causes cephalic displacement. So any condition which causes injury to the phrenic nerve from the central region to the periphery, like even in cardiac surgery, when we are doing open heart surgeries, hypothermia is there, which causes injury to the phrenic nerve, is an indication which causes raised diaphragm. Types. According to anatomical basis, diaphragmatic eventration may be complete, partial, or bilateral. On embryological basis, may be anterior, posterolateral, or medial. Going on the epidemiology, the incidence is very low as less than 0.05%. Male predominance is there, more commonly affecting the left hemidiaphragm. The incidence is likely higher than reported as most patients are asymptomatic and may remain undiagnosed. Pathophysiology. In a congenital eventration of diaphragm, stressed muscles are stressed out and aponeurotic. Neurogenic, which leads to neurogenic muscular aphasia of the diaphragm. These changes are lacking in case of acquired form. Seeing the history of the patient, there may be various presentation. Most are asymptomatic. Symptoms can be respiratory, gastrointestinal, or cardiac. Bilateral congenital diaphragmatic eventration in a neonate leads to acute respiratory failure and cyanosis. Respiratory symptoms, most common are the dyspnea on exertion, orthopnea, tachypnea, and shallow breathing. In adults, may present with recurrent respiratory infection or lung atelectasis, chronic cough. Chest pain may be there due to arrhythmia or palpitation. Patient may present with GI symptoms like dyspepsia, dysphagia, gastroesophageal reflex, epigastric pain, which can be worsened with increased intra-abdominal pressure due to exercise. Other intra-abdominal pathologies like ascites, infection, fluid sequestration. In infants, respiratory symptoms are because of shifting of the mediastinal structures to the contralateral sides. GI symptoms are most common and may be vomiting, bloating, constipation, poor weight gain, poor oral intake. In severe cases, gastric volvulus may be present. On physical examination, general tachypnea, central cyanosis may be present. Going by respiratory symptoms, findings, the use of accessory muscle is there, paradoxical movement of the chest during inspiration, decreased tactile fremitus and dullness to percussion, decreased breath sounds with presence of bowel sounds can be auscultated. GI symptoms, tenderness, on GI examination, tenderness may be present in epigastric or periumbilical areas. In infants, signs of blunt and penetrating thoracic trauma can be seen. GI examination, scaphoid abdomen, tenderness related to gastric volvulus may be present. Musculoskeletal neurological findings of Erb's palsy may be seen. Due to clavicle fracture, the arm is abducted, internal rotated, the forearm is extended and pronated. Now, for diagnosis, primary investigation is chest imaging. X-ray, both PA as well as lateral view is diagnostic. In X-ray, you see the elevation of ipsilateral hemidiaphragm and normal cardiomediastinal contour is seen. This is an X-ray showing the raised diaphragm over the left side with continuity. Again, PA and lateral view showing the eventration of diaphragm. This is PA view showing right-sided eventration, partial eventration, which may be confused with other conditions. CT chest, if diagnosis is not clear, intrathoracic or intra-abdominal abnormalities are suspected. CT chest shows elevation of ipsilateral hemidiaphragm, sharp edge of the eventration is seen. Diaphragmatic eventration can be differentiated from hernia due to normal attachment sites of the diaphragm in eventration. This is a CT scan showing the eventration. Test for assessing lung volumes and diaphragmatic functions are pulmonary function test, fluoroscopic sniff testing, and ultrasonography. Laboratory testing for associated congenital disease or infectious etiology may be done. PFT shows restrictive pattern. There is a reduction in FVC, reduction is in FEV1, and vital capacity decreases to 30 to 50% in supine position in eventration. Restrictive pattern mainly when eventration is bilateral and improves with plication. MIP and MEP are indicative of strength of respiratory muscles involved. MIP is reduced in patients with diaphragmatic eventration, whereas MEP is normal. Fluoroscopic sniff testing is used to examine diaphragmatic function and is done under continuous fluoroscopy. In diaphragmatic eventration, only a portion of a hemidiaphragm may show abnormal movement, while in paralysis, there is a paradoxical motion is seen. Ultrasonography of diaphragm is often used in place of fluoroscopy to evaluate diaphragmatic function due to its lack of exposing radiation to the patients. It shows normal respiratory thickness and diaphragmatic, the diagram is showing a normal diaphragm thickness, and on inspiration their thickness increases to more than 20%. If it is less than 20%, then the signs of paralysis is there. Congenital diaphragmatic eventration prenatally can be diagnosed with high resolution fetal ultrasound, CT, MRI. Prenatal diaphragmatic eventration is difficult to differentiate from congenital diaphragmatic hernia as lungs are hypoplastic and fetal stomach, liver and heart are visualized in the same transverse plane. So it is very difficult to diagnose both the condition in the prenatal condition. Postnatally, eventration is suspected when there is an elevation of a portion of diaphragm on the chest, radiography, when evaluating for respiratory distress. Confirmatory testing for diaphragmatic eventration is fluoroscopy, dynamic MRI, ultrasound. Management. Mostly dependent on etiology and severity. In asymptomatic patient or mild cases, supportive care is recommended. In cases of hypoxemia, oxygen supplementation by a mask or CPAP, non-invasive ventilation should be given. As infants commonly present with GI symptoms and failure to thrive, nutritional support should be optimized. In severe cases requiring mechanical ventilation or when patient fail to respond to medical management, surgical plication, that is surgical management, come into role. Procedure involves creating pleats with U-stitches in the weakened hemidiaphragm and then anchored down. Can be done. Approach can be open as well as open or minimal invasive approach via videoscopic VATS, laparoscopic or robotic surgery. Goal of treatment in eventration is to restore the diaphragm to normal location, restore normal capacity of hemithorax to allow lung growth in infant and children, to restore normal visceral location in abdomen, to stabilize mediastinum. The aim is to have more effective ventilation. It should be noted that surgical plication does not improve the function of the hemidiaphragm. Indications for surgery respiratory distress, unresponsive to conservative treatment, dyspnea that is not due to another process like heart failure, primary lung disease, infants with inadequate nutrition intake or failure to thrive, life-threatening or recurrent pneumonias, inability to be removed from mechanical ventilation. These are the pictures showing the central plication and radial plication. This is an intraoperative photograph in a 7-year-old child which we had operated in our department due to repeated chest infections. Additional or alternate treatment in which, in cases where plication is not indicated, is diaphragmatic pacing, neurotization, or both. Now on the differential diagnosis, diaphragmatic hernia is there, lung consolidation, subpulmonary pleural effusion, pleural mass, ascites, hepatic and splenic enlargement. Prognosis is generally good dependent on the severity and etiology. Diaphragmatic plication has shown to significantly improve symptoms and quality of life in patients with extensive eventuation. Procedure has also shown to improve FEV1 and FVC by 25 to 30% respectively. Thank you. Yeah.
Thank you, Dr. Saab. The question will be taken at the end of session. So our next talk on thoracic outlet obstruction by Dr. Manjunath. Yeah. Dr. Manjunath is a consultant thoracic surgeon at Apollo, Hyderabad. Sir, mic is yours.
Good morning, everyone. Thank you, the organizers, for inviting me. Greetings from Apollo, Hyderabad. Thoracic outlet is an anatomical area in the lower part of the neck. There are 3 spaces basically between the clavicle and the first rib. So this is a very tight area where the subclavian vein, subclavian artery and the brachial plexus are in close proximity, and there is a chance of one of these structures getting either compressed or there's a formation of a post-compression thrombosis and all that, leading to various constellation of symptoms, mostly confined to the upper limb, like pallor, paresthesia, weakness and muscle atrophy, and more importantly pain which is disabling the patient. So there are 3 triangles. The first one is the interscalene triangle. So you can see this is between the anterior and posterior, anterior and middle scalene muscle, and the lower margin is formed by the first rib. So this is the area, and you can see that the brachial plexus is coming out through it. That's the most vulnerable structure here, which can be compressed. This can happen, for example, if there is a muscle atrophy of any of this, or there is a damage of the muscle and there is fibrosis of this muscle, that can cause compression of this area. The other thing is